most unsettling and disruptive times in modern history. COVID-19 has altered how we venture into the public and how healthcare needs to approach medicine. However, Houston Methodist has experience with pandemics. It was founded a century ago when another deadly virus ravaged Houston, the Spanish flu. Now we stand on the shoulders of those giants who fought that pandemic. Their actions set the benchmark for medical innovation. It is with this in mind that Center for Critical Care will work to discover and introduce advances in critical care medicine for the benefit of patients and to be prepared and anticipate future needs.
We are in the second century of critical care delivery at Houston Methodist. The center brings much needed focus in areas of research, education, and clinical innovation together and integrates multidisciplinary areas at all of our Houston Methodist locations.
And comprised of 8 ICU locations, including the virtual ICU, and over 300 ICU beds in over 5 subspecialties, the center unifies clinicians and researchers practicing at Houston Methodist who are actively involved and dedicated to the continual improvement in critical care medicine. Working together and leveraging our centers of excellence for the benefit of our patients makes us uniquely positioned to revolutionize the future of critical care medicine, while our collaboration with academic and research institutes drive our spirit of innovation.
Over the years of my career, I've seen critical care undergo many changes, but never have I seen the pace of change be faster or the kinds of changes more profound than during this last year with COVID-19. That's why I'm so excited about the Houston Methodist Center for Critical Care. It enables us to share best practices, it enables us to integrate new technologies, and we're developing our academic mission throughout our great system.
When we look at the innovations from whether it was intubation boxes or the way that everything was done to bringing care into the room from outside of the room, from virtual family visits and others, it was amazing to watch the innovations that were happening inside of the ICU. And not only happening inside of the ICU, but then actually watching the publication after publication happen from the work that was being done at Houston Methodist.
I'm confident the center will achieve its mission through groundbreaking academic research and by collaborating within and outside of our system. Of course, there is no doubt in my mind that by continuing to partner with Houston Methodist Centers of Excellence to achieve shared goals in the spirit of leading medicine will ensure success for today and in the many years to come.
Good afternoon. So nice to see all of you live here today. My name is Atiya Dalla, and I'm an intensivist and pulmonologist here at Houston Methodist Hospital. I'm also the co-director of this year's 4th annual Critical Care Symposium. On behalf of Houston Methodist Center for Critical Care, I'd like to wish everyone a happy Earth Day. Every year on April 22nd, people around the globe come together to honor and conserve our shared home, the Earth, and also remind ourselves of the work still left to be done. On this Earth Day, people from around the globe have also come together to join our symposium. I'm very excited to welcome participants from all corners of the world, including Germany, Mexico, Brazil, Poland, Lebanon, Malaysia, Jordan, India, Pakistan, and Saudi Arabia, and of course, from the United States. As critical care practitioners, we've managed to not only survive, but thrive during the craziness of these last 2 years. I say we thrive because of one reason and one reason alone. We love what we do. It's true. Taking care of the patients and their families, that's what gets us out of bed every morning and sometimes in the middle of the night. Then there are our colleagues, without which we would be nowhere. We, all of us, have learned so much from our fellow practitioners. Today you'll hear from the best of them, some of the leading minds in critical care medicine. Before we begin, I'd like to make a few announcements. We gratefully acknowledge the following exhibitors for participating in this activity. Please take time to visit with the exhibitors during your breaks and meal times. We gratefully acknowledge GE Healthcare for providing an in-kind donation to partially support this activity. If you're watching online, please submit your questions in the chat box on the live stream page. If you're watching in person, you can submit your questions through that link posted there, and it's also in your handouts. You may submit your questions at any time during the presentation. The questions will be moderated and will be addressed based on time and content. Disclosure and CE information can be reviewed in the handouts provided at the registration desk or within the description area of the live stream page if you're watching online. You can expect to receive an email from Houston Methodist CME office within 2 to 3 business days to complete a survey which will prompt you to receive your certificate. For this year, we have tried to create a learning-rich environment covering all aspects of critical care medicine. So you'll see topics covering neurocritical care, cardiovascular, renal, pulmonary, infectious diseases, imaging technology, and pregnancy in critical care. We also have a great bunch of workshops giving you the opportunity to refresh your knowledge about ventilators, mechanical circulatory support, ECMO, and point-of-care ultrasound, and breakout sessions on neurocritical care topics and difficult conversations in the ICU. Without further ado, I'd like to introduce the Medical Director for the Center for Critical Care at Houston Methodist and also the Director of our Critical Care Symposium, Dr. Faisal Masood.
All right, great. So nice to see people in person. Thank you, Atya. Thank you for all the people who are attending us in person, for all the people online from different parts of the world. Well, compared to what we were last year, I'm so excited. And again, we'll have more people tomorrow also. This is a great panel of speakers, local, national, international speakers. The topics were chosen for a certain reason because really we want to expand the scope, how we look at critical care. And you'll see that today and tomorrow. Just to give you a little bit insight, you saw some of the introductory video of our Center for Critical Care. Our center, we are among 7 hospitals, we've got 15 ICUs. And just to give you a little bit of insight that all of the 15 ICUs of Houston Methodist Hospital System are Beacon Award recipients. This is the highest award which AACN, which is the Association of Critical Care Nursing, gives it. And to my knowledge, and we asked AACN also, we are the only system in the country in which every ICU is a Beacon Award recipient. Kudos to the nurses, basically. Not only that, the work with every person who works in the ICU makes a big difference. And that speaks in quality and patient safety. In Visitation, which is a cohort of about 125 top academic medical centers across the country, Houston Methodist is in the top 3 as far as mortality outcomes. And we are way ahead than a lot of non-institutions. And that's the whole teamwork. Everyone has a role to play. We're the 4th largest complexity of the patient, the 3rd, highest, lowest mortality-wise. Not only that, it's really all about the people. It's about the nurses, the doctors, the pharmacists, the physical therapists, the resident, the nurse practitioner, the physician assistant, the ward people, the support people, the PCA, the perfusionists. I mean, I can keep on saying. Critical care is really the whole microcosm of healthcare. We take care of the most sick patients, getting them through, and you'll see that today and tomorrow, that we are looking at not only getting them alive, but we're really focusing on them, what happens to them after they leave ICU. How do we address issues of diversity, equity, not only in patients and their families before they come to us, during they come to us, and afterwards? How do we look at technology to kind of integrate and make it more humane care? And again, that's one of the keynote speaker wise, but I'm not going to hold anything more. We're going to talk more tomorrow, but I welcome all of you. It is so exciting. I'm so happy. You know, this is my 25th year at Methodist Hospital, and this is our second year century of critical care. I'm so happy. I've never really been so happy because I'm an old-fashioned guy. I like to see people in person. So those of you who are joining on virtual, we're so happy you are joining from all parts of the world. We're so happy to have you. And I will give the cards to Dr. Dahl to really run the show. Thank you all for coming.
Thank you very much, Dr. Masood. It's going to be a lot of fun. I'm very much looking forward to every presentation today. We'll have one keynote speaker today and 3 other presentations. So, first on the agenda today is our keynote speaker, Dr. Stephen Trzeciak, joining us virtually. Dr. Trzeciak is a physician-scientist, chief of medicine, and professor and chair at Cooper University Healthcare in Camden, New Jersey. He's a practicing intensivist and a clinical researcher with more than 120 publications. He is also the co-author of 2 books, Wonder Drug, which will be out this summer, and his earlier book titled Compassionomics. Today, Dr. Trzeciak will teach us how compassionate care can improve patient outcomes and decrease physician burnout. His mission has been to bring compassion to the forefront of the medical profession. I invite everyone to read Dr. Trzeciak's full bio sketch, which is posted on our Symposium website. Please welcome Dr. Stephen Trzeciak.
Thank you. Thank you so much. I want to thank Dr. Dalla, Dr. Masood for the honor of allowing me to join you in the Critical Care Symposium today. I've got a lot that I want to share with you over the next 45 minutes or so, and therefore I'm going to just jump right in. But before I do that, I have an ask of all of you. And my ask is this. I'm asking you to join me in examining something familiar in perhaps an unfamiliar way. And specifically today, we'll be talking about compassion. And rather than looking at compassion and examining it through a moral, ethical lens or an emotional, sentimental lens, I want to ask you to join me in examining compassion through a lens of science. And so my talk today is entitled Compassionomics, and we call it Compassionomics because we consider it to be the convergence of the science and the art of medicine. And when you examine compassion through the lens of science, I hope what I share with you today will make you think that if we're as rigorous about examining the effects of compassion as we are everything else in the house of medicine, that we can in fact find beneficial effects, not just in meaningful ways, but also in measurable ways. And so what I'm going to do to start, I just want to acknowledge something, and I just want to acknowledge where we've been over the last 2 years. This is an article, it was the Easter Sunday Center spread in the New York Daily News, Compassion Saves Lives, and my colleague and co-author Anthony Mazzarelli and I had the honor of writing this, but if you've already perhaps you've already noticed, this was Easter Sunday 2020. Little did we know when we were writing this that 2 years later, we would still be, to some extent at least, and hopefully on the backside, but still in the midst of the effects of a pandemic. It's been a really long 2 years. All of you in critical care at Methodist and everywhere else that's watching today virtually has been through a lot in the last 2 years. We certainly have here in our program here at Cooper in New Jersey. And we wrote this, Compassion Saves Lives, to highlight the fact that it's not just compassion for patients and compassion for families, it's compassion for each other. And what's the evidence that taking good care of each other is associated with being sticking together more closely and making it through to the other side. I'm a believer wholeheartedly that compassion for each other is one of the main things that saw us through. But we also have to acknowledge a confluence of crises, because we had an epidemic of burnout before we ever had a pandemic. And then on top of it, we have what some people are calling a demographic drought. But if your hospital is like mine, you are going through workforce shortages like never before. And it's a perfect storm of burnout, a pandemic, and not enough people to take care of the patients that we have, and more strain on the people left behind. All of these three things combine to why I believe that compassion matters now more than ever, and that this is a pivotal time, not just in medicine, but quite frankly in history. And so just some conventional disclosures. I don't have any relationships with commercial interests, and the proceeds from Compassionomics and from Wonder Drug go to our charity at Cooper, which is called the Cooper Foundation. But I do have some unconventional disclosures I want to share with you, because I think these are important. Number one is I want to assure you all that I do not have any magical thinking about compassion. No magical thinking. There's no Pollyanna beliefs. And let me say it this way. The number one determinant of clinical outcome is clinical excellence. The number one determinant of clinical outcome is clinical excellence. If you're a physician who prescribes the wrong medication, or a surgeon or proceduralist who has a major technical error, there's no amount of compassion that's going to undo that, of course. But it's not an either or, it's an and. So when our book first came out, there was an article in the Washington Post, and the social media tagline to the article said, would you rather have a physician who graduated at the top of the class in medical school, or one who was compassionate? Either or. Do not take the bait. Don't take the bait on that line of thinking. It's a false choice. And so I don't have any magical thinking about compassion, in that everything I share with you today is predicated on the understanding of clinical excellence. If we have clinical excellence first and then compassion in addition to it, that can yield the best possibility for the best outcome. The last thing I want to acknowledge is, you might think that because I was invited to speak with you all today about compassion, I wrote a book about compassion science, that I must be the most compassionate doctor. But let me assure you, I am a work in progress, 100%. And thankfully, science shows that change is possible, and I can get better. And that's why I'm working hard at getting better at compassion every day. And I'll share with you some data on that a little bit later. So just a little bit about how we got here. I spent the first 15 years of my career at Cooper. This is before I was the chair of medicine. I was studying resuscitation science in the ICU. And I was not in the market for any sort of change in trajectory for my research career. We were studying brain injury after cardiac arrest, and specifically we were trying to identify the optimal oxygen content in the blood that would lower the risk of permanent disability from brain injury following resuscitation from cardiac arrest. Everything was going as planned. We were publishing in good journals. We were getting grants from the NIH. Everything was great. And then an unexpected question from a 12-year-old literally changed the trajectory of my research and really my life's work. It turned everything upside down. And that 12-year-old was my son. And one evening we were at home, he asked me for help. He said, "Dad, I know you give a lot of talks for your research. I have to give a talk for my class at school. Can you help me prepare mine?" And I thought, this is going to be awesome. What a perfect father-son bonding opportunity. Little did I know what was in store for me. So I said, sure, what's to talk about? He reaches into his backpack and he pulls out a sheet of paper and he puts it down on my desk. And on that sheet of paper was the assignment for his talk at school. And the question was this: what is the most pressing problem of our time? 7th grade. I don't know what you all were doing in 7th grade. I was not doing what is the most pressing problem of our time. And what he picked isn't actually what's important. What's important is that he believed it, because after talking about this over the next few nights, what we realized together is that there's no such thing. There's no one single most pressing problem of our time. The question is, what is the most pressing problem of our time for you through your lens of experience in your little corner of the world? And after going through this exercise, I went through this period of introspection, and I had to find the most pressing problem of our time for me. And then I found it. But before I tell you what it is, I want to tell you a story. So picture this. On February 27, 2007, on a snowy stretch of highway outside of Uppsala, Sweden, 2 buses collided head on. So this is what was left of one of the buses, literally sheared in half along the long axis. And the extrication of victims was so difficult that this case literally made its way into the annals of a disaster medicine textbook. And tragically, 6 people died, but miraculously, somehow 56 people survived this wreck. Now, researchers, 5 years later, researchers asked the question, what do survivors remember? What do survivors remember? And they used a rigorous qualitative research methodology, interviewed every survivor, and they found 2 common themes in the data. The first was expected. It was the physical pain that they felt at the moment of impact. But the other theme, it was a lack of compassion from the caregivers at the hospital. Now, what's more striking is when you read the methods section of this paper and you realize that the victims were taken to multiple different trauma centers, yet they had the same experience. What they remembered 5 years later wasn't the type of external fixator that they had on their leg or what medication went through their IV. What they remembered is how they were made to feel in that moment. And these data begin to open my eyes to a stark reality. In healthcare, we're in the midst of a compassion crisis, literally, an erosion of compassion. And you may say, well, that's just true in society in general, and maybe it's just spilling over into medicine, and there's evidence for that. So a University of Michigan meta-analysis has found that empathy among college students has been declining over the last 20 years, and the speed of that decline is actually accelerating. Researchers from the Harvard Graduate School of Education found in a study of 10,000 middle school and high school students that 80% of our youth believe that their parents value their achievements and their accolades more than they value the kids' kindness to others. And in a striking Pew Research study from just a few years back, fully 1/3 of Americans endorse that they don't consider compassion for others to be among their core values that describes them well. But what about healthcare? Healthcare is supposed to be different, right? Well, a health affairs study from investigators from Harvard Medical School found that in a study of Americans, 46% of Americans believe that our healthcare system is not compassionate, but they also believe that nearly half of our healthcare providers are not compassionate. Physicians specifically miss 60 to 90% of opportunities to respond to patients with compassion. And in the context of office visits, compassion comprises less than 1% of all physician statements to patients. So in our domain, critical care, researchers from Johns Hopkins University have found that 74% of interactions between the ICU care team and patients and families in the ICU are devoid of compassion. And the most striking, in my opinion, is a University of Washington study that was funded by the NIH found that in end-of-life conversations in the ICU, fully 1/3 of the meetings between the ICU care team and patients and families in the ICU had zero expressions of compassion from the care team to the patients and families. And that was at the end of life. We know we had an epidemic of burnout going into this pandemic, and what the research shows is that 35% of U.S. physicians have at least a moderate level of depersonalization. So that's an inability to make a personal connection. And of course, although electronic health records save people's lives, there's no doubt about it, there's also ample evidence of an unintended consequence that healthcare providers spend more time looking into computer screens than looking patients in the eyes. I want to share with you this work of art. This is Luke Fields, the doctor. It hangs on my wall here at Cooper. I have it on my wall because it's a constant reminder to me of what healthcare, what caring for patients is supposed to be all about. This is Dr. Murray, by the way, is the doctor depicted in this painting by Luke Fields. He's completely locked in, totally in the zone. You couldn't distract him if you tried. Now, there was a wealthy benefactor for Luke Fields. He said, "You can paint anything." And Fields said, "Anything?" He said, "Anything." And the benefactor let him paint whatever he wanted. Fields painted this. Why? Why did he remember this moment with vivid detail? Because he was there. He was the little girl's father. After his death, his surviving children said that the reason why he painted this moment with Dr. Murray was because he would never forget not only his dedication, his commitment, but also his compassion. It was something about this moment that stayed with Fields. And what I'm going to argue through this talk today is that there's something about healthcare experiences, especially in emotionally charged situations with critical care, but there's something about healthcare experiences that just stay with people. And 13 years after his daughter's death, this is what Fields remembered in vivid detail, never to be forgotten. So I'm going to contrast this with another work of art. This one was published in JAMA in 2012. The pediatrician is on the far left of this picture, and he submitted this drawing to the journal because he was mortified that this is how his patient saw him. The artist is the patient, the 7-year-old girl on the exam table in the middle of the drawing. And what is the physician doing as he's depicted here? Facing exactly the opposite way and staring into a computer screen. So that was then and this is now. And based on all of the data that I've shared with you and more that I could have shared, I conclude that we not only have an erosion of compassion in healthcare, we do in fact have a compassion crisis. And for me, through my lens of experience as a physician scientist and as a leader, and in my little corner of the world, this is the most pressing problem of our time for me. And that's why I continue to not only think about this every day, but actually focus our entire research program on this. But it begs a question. The question is this: so what? Does compassion really matter? Now, I don't say that to be provocative, but what I think it's an important question, because some people believe that compassion is just a nice to have, like a cherry on top, so to speak. Does compassion really matter? And so you may say, of course, compassion matters. It's the cornerstone of the art of medicine. And of course, I agree. I've always agreed. But that's not the question. Is compassion just in the art of medicine, or are there also evidence-based effects belonging in the science of medicine? And what's the evidence? So Anthony Mazzarelli and I came up with our hypothesis. And the hypothesis is that compassion matters, not just in meaningful ways, but in measurable ways. And so our hypothesis is compassion matters for patients. Compassion matters for patient care, the quality of care, the cost of care. And what I'll conclude with today in just a bit is that compassion also matters for those who care for patients, for us, and that compassion actually builds resilience and resistance to burnout. So before I jump into all that, and I'll share with you that we did a quasi-systematic review, went through 1,000 scientific abstracts. There in Compassionomics, for example, there are over 280 original science research papers cited in the book. And so what I'm sharing with you today, and I won't have time in the short time that we have today to go through a ton of data, but these things aren't what I think about. They're not what I think, not what I believe. It's not my opinion. It's just what we found when we went on a journey through the evidence. So I share that with you today, and then you can make up your own mind. I hope that you find something that I share with you today to be helpful. But one thing that we do need is nomenclature, clear nomenclature. We need to be clear about terms. So compassion is typically defined this way by people who do research in compassion. It's an emotional response to another's pain or suffering, involving an authentic desire to help. So it's different from it's distinct from a closely related term, empathy. So empathy is the sensing, detecting, feeling, and understanding component, but compassion goes beyond empathy, and that it involves taking action to alleviate someone's pain or suffering to whatever extent is possible. And an easy way to remember it would be empathy plus action equals compassion. Actually, Don Berwick thought that up years ago. But it's important to recognize that these aren't just semantics. There are neuroscience data for these distinctions in terms. So for example, using functional MRI, researchers have found that when you bear witness to people who are suffering, you have empathy, it actually activates the pain center of your brain. So there's neuroscience behind the saying, I feel your pain. And similarly, or actually distinctly different, when your mind is focused on helping, taking action to help someone alleviate pain and suffering to whatever extent possible, a distinct neural structure is activated, not your pain center. It's actually considered a reward center of the brain, reward center. So it's positive emotion, positive affect, feelings of affiliation. Now, we all know this experientially because we know that it's really uncomfortable to bear witness to suffering. It's uncomfortable. We know that experientially, but it also feels good to help people. And there are many reasons for that, but one of them is activation of a reward center in the brain when we're taking action to help. So those are the terms. Before I jump into effects for patients, I just want to answer the question, does compassion matter for health in the broad sense? And what the research shows is that for good health and longevity, human connection matters. And so this slide depicts the Harvard Grant Study, which is formerly called the Harvard Study of Adult Development. It's the longest running study of any that I'm aware of. It's been going on for over 80 years. They're on their fourth study director. And what they did is they enrolled teenagers in Boston. Half of them were Harvard students and half of them were Boston teenagers not enrolled in college. And they followed them over time. Really what they wanted to do was unlock the keys to good health and longevity. And what they found is totally striking, in my opinion. What they found is that the best predictor of good health and longevity into your 80s isn't some biomarker. It's not your cholesterol, your systolic blood pressure, your hemoglobin A1C. It's none of those things. The best predictor of good health and longevity into your 80s is actually the quality of your relationships. The quality of your relationships. And we know that the flip side of that is also true. We know that loneliness kills. Our current Surgeon General has written a book about this. And the data in the public health literature are striking that with loneliness, not only is your sympathetic nervous system constantly activated, your stress response constantly activated from the experience of constant chronic loneliness, but also there are health effects. And so the effects of loneliness have been found to be comparable to smoking, obesity, and alcohol misuse with respect to risk of early mortality. So loneliness kills. But these are long longitudinal studies. What about in the context of patient care, where we have shorter episodes, and especially in our discipline, critical care, episodic care? What are the effects of compassion on patients? Well, in Compassionomics, there are more than 100 papers on effects for patients. And we break them down into 4 different categories. There are 24 different potential mechanisms of action by which compassion can have measurable beneficial effects on patients. The 4 categories would be physiological effects, psychological effects, effects on quality of care, effects on patient self-care. Because this is a critical care conference, I'm going to leave out a lot of the things that don't apply to critical care medicine. One of the things that I do want to share with you is related to the quality of care. And so I'm going to show you some associations that I think are really important. Now, when you see data on association, we don't infer causation, but in my opinion, a causal pathway is not hard to imagine. So researchers from the Mayo Clinic have found that in healthcare environments where there's less caring, patients are less safe. And the way they did this is in studying the different pillars of the burnout syndrome, one of which is depersonalization. Depersonalization, we said, was the inability to make a personal connection. So they measured depersonalization in the context of hospital practice with resident physicians. And what they found is that physicians who were moderate to high in depersonalization had a strikingly higher odds of a major self-reported medical error over the next 90 days. And when I talk about the causal pathway not being hard to imagine, this is a study from the University of Washington finding that with high depersonalization, there was almost 5 times higher odds of self-reported suboptimal care, meaning in the context of the confidentiality of this study, admitting that they had incidences where they provided care that they knew was suboptimal, which is, in my book, another term for that would be cutting corners. And so it's not too hard to imagine a causal pathway if you've had the experience like mine, like I have, when you work with colleagues that you just sense that they just don't really care very much. If you've seen what I've seen, they often are somewhat sloppy in the care that they provide. Now, again, that's association. I'm not inferring causation, but they go in the same direction where people who don't care very much, and in this case have depersonalization, the inability to make a personal connection, over 90 days, they're more likely to make a major self-reported error. And the same group of investigators from Mayo studied this in almost 8,000 surgeons in the American College of Surgeons and found that with high compared to low depersonalization, there was a 2 to 3 times higher likelihood of having a self-reported major surgical error over 90 days. I do want to share with you some data as it relates to, and this is going to go into segue into another thing that I want to talk to you about today because I think it's important for a critical care forum. But these data, by the way, go back decades, even the 1960s. So 2 papers side by side here on this slide, one from JAMA and one from the New England Journal of Medicine, from the Department of Anesthesiology at Mass General. What they studied was something that they called special care from the anesthesiologist. So imagine you're about to be wheeled in for surgery, similar to if you're about to be whisked off from the emergency department to the ICU. It may feel like the most vulnerable time in your life. What these investigators found in an experimental design, randomized trial of special care from the anesthesiologist versus usual care, and special care from the anesthesiologist was an extra visit from the anesthesiologist that was based on rapport building, allaying patients' fears, and was rooted in compassion for patients. And what they found is that when they compared the human connection of the special care visit from the anesthesiologist to a powerful sedative, pentobarbital. They found that patients that were treated with pentobarbital were drowsy, but even though they weren't calm, whereas patients were treated with special care from the anesthesiologist were calm, even though they weren't drowsy. They also had a follow-up study showing that special care from the anesthesiologist, randomization of special care, was associated with lower opiate pain medication requirement following surgery. Now, I didn't say that compassion from one to another eliminates pain, because of course compassion can't do that. But what we do know from experimental studies in laboratories is that the touch of a trusted other can attenuate another person's experience of pain to some extent that is measurable. And essentially, researchers have figured this out in a laboratory where I don't know who signs up for these kinds of studies, but where you get electrical shocks or cold therapy or heat or something like that, the touch of a trusted other can attenuate some experience of pain to an extent that is measurable. In the clinical realm, human connection has been associated with lower experience of pain, not only in postoperative pain, but also patients with chronic low back pain undergoing physical therapy, patients with headache pain in a migraine headache clinic, patients with abdominal pain related to irritable bowel syndrome. So there is something about human connection that can modulate a person, again, not eliminate, modulate or attenuate another person's experience of pain. From a physiological sense, there's also evidence that compassion can modulate stress-mediated disease. Since we don't have a lot of time to go into all that doesn't apply to critical care, I do want to instead steer a different direction and talk about something that, in my opinion, definitely does apply to critical care. And I am really, I spend a lot of time thinking about this question. What do patients remember? What do patients remember? So for example, I shared with you the data about the bus crash. Well, 5 years later, they didn't remember what kind of medications they were treated with or what kind of surgery they had or what kind of therapies. What they remembered was how they were made to feel in that moment of vulnerability. And there's something about that healthcare experience that stayed with them 5 years later. In this case, it wasn't compassion. It was actually a lack of. I shared with you that for Luke Fields, what he remembered 13 years later was, in vivid detail, by the way, exactly that moment where Dr. Murray tended to his gravely ill child with compassion. It also reminds me of a story I'm going to share with you quickly. So a while back, I was making rounds in the Viner ICU here at Cooper, and there was a gravely ill patient in his mid-50s. He was dying of septic shock. We were doing absolutely everything that we possibly could to try to save him, but it looked like he was not going to make it through the night. I had to share that news with his sister, who was just a few years younger than he was, and it was a really difficult talk because he had been her rock throughout her entire life. And after that really difficult talk, as I was about to get up to leave, she asked me a question that I don't know if I've ever heard it before in the ICU. She said, "You don't remember me, do you?" And I said, "I'm sorry, I don't." She said, "It's okay. It's okay. You are so busy in here. You have so many patients. I wouldn't expect you to remember me, but I need you to know something." She took her hand and she pointed it we were standing in bed 25 in the Viner ICU, and she pointed it to bed 8 right across the hall. She said, "I need you to know something. 7 years ago, my mom was a patient in that bed right over there, and she was dying, and there was nothing that could be done to save her. Nothing could be done to save her. And she was dying, and you were her doctor, and you had to tell me that. So you and I, we've had this talk before, and it just took my breath away. But what she said next is something I'll never forget as long as I live. What she said next was this. She says, "But I need you to know something. That was 7 years ago. And it was terrible because I was so close to my mom, and I think about her death every day because we were so close. And it's painful even now, but I need you to know, those nurses, and she used the word kindness. She didn't say compassion. She used the word kindness. She says, I need you to know the kindness of those nurses. They held me, and they let me know in those days when she was dying, they let me know I wasn't going to go through this alone, that they were there with me. And when I think about my mom's death, and it comes back to me even now, every time it comes back to me, the memory of those nurses and their kindness comes back to me too. And it makes me feel better, even now, 7 years later. So those nurses went home from their shift. Now, they're Olympic champions in compassion. That's what they do every day. They probably didn't even think anything of it when they got home that night. But for this patient, and I said there's something about healthcare experiences that stay with people. I don't know if it's because the amygdala, where we experience intense emotions, is right next to the hippocampus, but there's something about healthcare experiences that stay with people. For this woman, it was 7 years later, and the kindness that was shown to her by those nurses in those days not only came back to her in an echo chamber and reverberating over and over and over again over time. It not only came back to her, it actually made her feel better. It was therapeutic to her even 7 years later. So I teach my medical students, interns, residents, fellows in critical care, I teach them this power. And what I teach them is that now what I do is I pause before I go into the room to have any discussion that for any reason could be emotionally charged. Because data show quite clearly that people suffer emotional harms in healthcare because there's something about healthcare experiences that stay with people. And I ask my residents, I tell them the story about this power and ask them, what do you want to be remembered for? And remember, after you go home tonight, whatever you're remembered for, you won't remember it, but it will reverberate and go on and on and on and on for these people that you care for. And so I'm interested in this question, what do patients remember? My colleague, Brian Roberts, who's our science director, is studying this right now. What he is studying specifically, and I'll just be brief in the interest of time, but he is studying if we can impact post-traumatic stress disorder, which we know in critical care, it's about 25 to 33% of patients who go through critical care, specifically in this study, a life-threatening medical emergency, will meet diagnostic criteria for PTSD symptoms 30 days and beyond. So his hypothesis is that if we meet people in the moment and talk to them, not about them, and we do what we can to allay their fears, that perhaps we can prevent PTSD and prevent psychological trauma rather than trying to react to it or treat it after it's already set in. So I shared with you a lot about the why for compassion, but what about the how? Let's say I've said something today that makes you think, I want to get better at compassion. Well, I didn't think it was better to get better at compassion or possible to get better at compassion. I actually used to think that we were either wired for compassion or we're not, and thankfully the data shows otherwise. I'm not a believer in checklists. I'm a believer in a mindset, because people find different ways to connect, and if you have a compassion mindset, of which I think there are 3 components, then you will find your way for that meaningful connection. If you don't have the compassion mindset, it becomes very difficult, in my opinion. So there are 3 key elements of this. Number 1 is recognizing that there is, in fact, an evidence base for compassion in the domain of medicine. Once you realize that, and that there is an evidence base for compassion, you feel different about the compassion that you wield, so to speak. You feel different about the opportunities for compassion because you feel that it's not just a nice to have. You know that there's actually measurable benefit, but in some cases powerful benefit there. And it makes you use your compassion differently. So number 1 is just recognizing there's an evidence base for compassion. Number 2 is change is possible. And number 3 is all about time. So I already told you about the evidence base. Number 2, change is possible. Again, I didn't used to believe that. I thought we were either wired for compassion or we're not. But the evidence, both inside of healthcare, is in this study from my colleague here at Cooper, Sundar Patel, and others, as well as outside of healthcare in the psychology research domain, have shown quite clearly that compassionate behaviors can in fact be learned, taught and learned. And in this case, in this study, systematic review, 56 papers of heterogeneous empathy and compassion training curricula were tested, and in 3/4 of these studies, they in fact moved the needle on compassion in some measurable way, typically from the patient perspective. So change is possible. The key is having a growth mindset. Now, if you're familiar with the mindset work by Dr. Carol Dweck and others, this relates to education. What they found is that kids coming up through school, if they had a fixed mindset, meaning they think intelligence is a trait, not a set of skills, when they experience difficulty and failure, they take it personally. And they internalize that and they stop trying. Whereas kids that have a growth mindset, they don't see intelligence as a trait, they see it as a collection of skills. Those are the kids that realize that if they experience difficulty, they just need to work hard at it and work more, and they'll get there. Well, what a lot of people don't know is Dr. Dweck and colleagues also studied this for compassion. And what they found is that people who realize that compassion is, they have a growth mindset about compassion, they look at compassion as a collection of skills rather than that they can develop, rather than a trait that they're born with. Those are the people who will persevere when compassion is difficult and will get better at compassion over time. This is good news for me indeed, because as I told you, I'm a work in progress. Because of this, I work hard at compassion every day. I work at this in the ICU with my patients, their families, with my colleagues, with the nurses, the entire staff. I work at this just like I work on my technical skills with endotracheal intubation or pulmonary artery catheterization. I work on compassion, and I definitely don't get it right all the time, but thankfully science shows that over time, if I have a growth mindset and I work hard at it, I can get better. The last thing for the growth, for the compassion mindset that I want to share with you is all about time. It's all about time. So 56% of patients in a recent journal of general internal medicine, 56% of physicians in a recent journal of general internal medicine study said that they don't have time to treat patients with compassion. Begs the question, how much time does it actually take? So researchers from Johns Hopkins wanted to know the answer to that. So they used an experimental design, a randomized trial in 280 subjects, the vast majority of whom were breast cancer survivors. And the primary outcome measure for this experimental study was patient anxiety, measured with a validated scale. And if you've ever had cancer or someone close to you has had cancer, then you know that anxiety is a pretty important outcome measure. So they randomized patients to an information-only consultation with an oncologist or an enhanced compassion intervention. And what they found is the enhanced compassion intervention was associated with a measurable, statistically significant reduction in the anxiety level of these cancer survivors. So what was the intervention? Instead of describing it for you, I'm just going to read it for you. So this was the message from the oncologist at the beginning of the consultation. I know this is a tough experience to go through, and I want you to know I'm here with you. Some of the things I say today may be difficult to understand, so I want you to stop me if something is confusing or doesn't make sense. We're here together, and we're going to go through this together. And then at the end of the consultation, the oncologist said, I know this is a tough time for you, and I want to emphasize again, we're in this together. I'll be with you each step along the way. So how long did that take? They measured it, it was 40 seconds. So 40 seconds of compassion was all it took to make not only a meaningful connection, but one that had a statistically significant reduction in patients' anxiety level in a measurable way. And so we found other studies that show compassion doesn't take as long as we actually think. And some of my colleagues bristle at this slide. They hate it actually because they say there's no time dimension at all. You can go through your day with brusque efficiency, letting everybody know how exactly how busy you are or how busy you think you are, or you can treat people with compassion. And if I held a stopwatch to you, it actually wouldn't come out to be much different at all, or perhaps not even any different. And so why is it that we feel compassion takes time? And so this was a University of Pennsylvania study that was highlighted in a Boston Globe article. What they did is they randomized people to 4 different uses of time, and they measured something called time affluency. Time affluency, that's the feeling that you have plenty of time, that you're not in a hurry. And they wanted to know what uses of time increase one's feeling of time affluency, feeling that you have plenty of time, not in a rush. They randomized these study subjects to wasting time, getting an unexpected windfall of free time, spending time on yourself, or lastly, and the only one that actually made a difference, increasing time affluency, it was spending time helping other people. There's something about spending time helping other people that makes us feel different about the time that we have. And so what I want to do, just in closing now, in the few minutes that we have left, I want to share with you a story really of where the science meets the personal. So after 20 years of working in the ICU, and as you guys know, we meet people and their families on often what's the worst day of their life. And after doing that for 20 years, I became keenly aware that I had every symptom of burnout myself. So what was I supposed to do? Well, I'm a research nerd, so I went to the data, looked in PubMed. And what I found were things that I call escapism. Take more vacations, take more nature hikes, do more yoga, just get away more. And I think that work-life balance, yoga, nature hikes, and vacations are all important, but I wasn't buying it. It didn't compute for me. It didn't compute because I believe that the antidote to burnout had to be something fundamentally different at the point of care, not an escape. And that's when we were doing the work for Compassionomics, and I became aware of the data that compassion can be a powerful, beneficial therapy for the giver too. And so I remember being taught in medical school as a third-year med student, my first week on the wards. I remember being taught, and of course, this is the hidden curriculum, not the overt curriculum. I remember being taught, now listen, don't care too much, because too much caring burns you out. As if being uncaring was like some sort of emotional shield. So I believed that for 25 years until I actually looked into the evidence myself. And what you see when you look at the data is that there is an association between compassion and burnout, but it's inverse. So if what I was taught in medical school, too much caring, too much compassion burns you out, it would have been in the same direction. High compassion, high burnout, low compassion, low burnout. What you see, the preponderance of evidence in the literature shows an inverse association. High compassion, low burnout, low compassion, high burnout. Well, what can explain that? Well, my hypothesis is that if you connect with patients and families and staff for that matter, faculty, nurses, everybody with compassion. And by the way, in the psychology domain, the evidence shows quite clearly that the key to resilience is relationships. The key to resilience is relationships. So if you connect with compassion, with patients, family, with everybody around you, but especially with those you're caring for, then you get the fulfilling part of medicine. You get the good part. And if you don't, then perhaps all you really have is a super stressful job. And so what the evidence really shows with this inverse association is the people with low compassion are the most at risk for burnout under the same amount of stress. So what was I supposed to do? I became aware of this data and I did what I call my N of 1 experiment. N of 1, I was the one study subject in this experiment. And I decided very intentionally to test the compassion hypothesis for myself. And so very intentionally, I connected more, not less. Leaned in rather than pulled back and detaching and escaping. And the key to resilience is relationships, and I invested more in those relationships around me. And that was when the fog of burnout began to lift for me. And so testing the compassion hypothesis for me changed everything. And you all know the data just as well as I do. So a high proportion of people that are in this Zoom right now are probably going through burnout themselves. I suggest to you that you test the compassion hypothesis for yourself. Give those around you your 40 seconds of compassion every opportunity that you have, and see how it transforms your experience. But don't do it because I said so. Instead, do it because the science says so. So in closing, the science shows that compassion actually belongs in the domain of evidence-based medicine. And compassion has powerful beneficial effects for patients, for patient care, and for those who care for patients. And I just want to thank you all for your attention today. Time is your most precious commodity, and so I want to thank you for sharing it with me. Dr. Dalla, Dr. Masood, thank you very much. I know we just have a few minutes left, but if there are any questions, I'd be happy to take them. Thank you.
Thank you so much, Dr. Treziak, for enlightening us on this very, very important topic. Very informative, very useful for our daily practice. Does anybody in the audience have any questions to start us off? I guess I'll ask the first one then. Dr. Treziak, it's a two-part question. So what accounts for the lack of compassion in the medical field, or society for that matter? And if someone doesn't know this skill, can you actually teach a healthcare professional how to get compassion? Because I know it's considered a soft skill, and some have it, some don't. So I just, and people who have already finished med school, it wasn't in our curriculum, as far as I can remember growing up. So how would you?
So the evidence supports that compassionate behaviors can in fact be learned. There are multiple systematic reviews on that. I think more than anything else, though, it's the desire and more importantly, the recognition that change is possible. And so Dr. Dweck's work in the growth mindset and specifically with compassion, those who believe that compassion is a skill get better at it over time. And when compassion is difficult, because let's be honest, there are a lot of times when compassion is difficult. The people who believe it's a skill are more likely to persevere in those moments. So I think it's really a question of mindset more than anything else. And I would encourage you to adopt that mindset because of the beneficial effects for yourself. I don't mean it to sound like like a what's in it for me sort of thing, but what you'll find as an unintended consequence, so to speak, or a byproduct of connecting more is that just as all the research in the psychology domain shows that more connections, not less, will actually promote resilience, and you'll actually love your job more.
Thank you, Dr. Treziak. We have a couple of questions from the audience. Is there evidence showing an inverse relationship between compassion and litigation? Good one.
Yes. So in a word, yes. What we did is we curated all the evidence on litigation, and just long story short, what the research points to is that if your patients and their families believe that you cared, and that you actually cared, you're less likely to get sued. And if you have a relationship, you're less likely to get sued. The converse is you can do everything technically perfect. And we all know that bad outcomes happen even with technically perfect care. But if they think you don't care, you're more likely to get sued. The actual negligence and the incidence of litigation is actually not very well correlated. There are a lot of cases with no negligence that get litigated, and a lot of cases with high negligence that never get litigated, and relationships and specifically compassion are a way to mitigate that. And I teach my residents this all the time, but of course, that's not why to treat patients with compassion. Again, it's just an unintended byproduct or an unintended consequence that actually your risk of being sued will go down.
Thank you again, Dr. Treziak. We hope you'll visit us sometime in Houston, and thank you so much for this enlightening presentation.
My pleasure, and thank you so much for the opportunity.
Our next speaker's Twitter handle describes him as a fan of bugs and resistant genes and salsa dancing. We know him as Dr. Cesar Arias, the Chief of Division of Infectious Diseases at Houston Methodist Hospital. He's also professor and chair and co-director of the Center for Infectious Diseases Research, Weill Cornell Medicine. Dr. Arias is a nationally and internationally recognized physician-scientist conducting NIH-funded basic, translational, and clinical research on mechanisms and molecular epidemiology of antibiotic resistance. Dr. Arias founded the Molecular Genetics and Antimicrobial Resistance Unit, an international center for microbial genomics at Universidad El Bosque, Bogota, Colombia. Dr. Arias holds a PhD from Cambridge University in England. Today, Dr. Arias will discuss how basic science can be used to develop innovative approaches to study antimicrobial resistance and the use of translational strategies to individualize the treatment of multi-drug resistant organisms. I'm looking forward to learning a great deal from this talk. Please welcome Dr. Cesar Arias.
Thank you very much for this kind introduction, Dr. Masood, and all the organizers of this symposium. It's really a pleasure to be face-to-face. I did my best to be here, and I'm very glad that I'm here now sharing this with you. I do Twitter, and that's where she got that, and I do love salsa dancing if you are interested. So some disclosures, those grants that I have terminated in the last 24 months, I do not receive any personal money from any of these companies. This was all research grants. Okay, in these 25 minutes, I'm gonna try to talk to you about another crisis. This is a crisis that I call the silent pandemic, which is the crisis of antibiotic-resistant organisms. If we didn't have any pandemic at this moment, that will be the top public health problem of the 21st century. And even if we have a pandemic, that continues to be and continues to grow. So I'm going to focus in multi-drug resistant gram-negative organisms because I will show you that that's all the priority. And I will discuss a little bit of the clinical impact, some mechanistic basis of how, as infectious disease physicians like myself, approach these patients and treat these organisms, and how we can develop some sort of personalized medicine in infectious diseases, which is becoming more and more common. And I'm going to tell you about new drugs that are available and new drugs that are hopefully coming to treat these organisms. But before I start, I want to put this in perspective. I want to show you this. We all in this room have been in contact and received a prescribed antibiotic. You know, the antibiotics are the most common drugs really prescribed in clinical medicine. And you look at here, what is the impact of antibiotics in medicine? Look at these infections, hospital pneumonia, endocarditis, the pre-antibiotic rate, the death with antibiotics, and the changes in death without treatment. So the change is massive. And we don't think about that because we always can put antibiotics. at any patient, at any point, at any time, right? Compare this with this, hard survivals with anticoagulant drugs, that there are several mechanisms to do that. Compared to antibiotics, these blockbuster drugs are only 3% change in mortality. And then if a drug is expensive, like antibiotics expensive, everyone explodes. But if a blockbuster drug comes along and costs $100,000, oh, that's okay. So that's part of the problem, and I will discuss that later, how that has prevented the development of new drugs and why we are in the crisis that we are, or as part of the crisis. So antibiotics save lives, period. So in this context, the World Health Organization and CDC have organisms that are really critical priorities. And the critical priorities at these moments are Acinetobacter, Pseudomonas, and the Enterobacterales that are resistant to carbapenems and resistant to ESBLs, or extended spectrum beta-lactamases. And I'm going to try to put in context these organisms. But there are other organisms that are gram-positives, there are fungi, Candida auris, that are coming along and are affecting our most vulnerable patients. In our hospital here at Houston Methodist, are high complexity hospitals. I go to bedsides scratching my head, sometimes not having options to treat the patients. So we are at this point, and what I call post-antibiotic era, where we had to deal with many, many different circumstances and try to get information, mostly from basic science, to try to treat these patients infected with these superbugs. So I'm going to start just to put you in context of a bacterium. You know, remember, bacteria have been on the face of the earth millions of years before the humans walk into this. So the flexibility, evolutionary flexibility of these organisms is amazing. We've been actually surrounded of antibiotics molecules because they are mostly from natural products. So the drug that I'm going to talk about, or type of drugs, are the beta-lactams that we're all familiar to. These beta-lactam antibiotics function by inhibiting these proteins called penicillin-binding proteins that basically produce the cell wall of bacteria in this space that we call the periplasmic space. If you inhibit that, like the beta-lactams do, they are natural product, bacteria has enormous osmotic pressure because they divide every 20 minutes or even less, and they basically explode, or they die. So that's how antibiotics work. In order to get to the target, they have to pass a really treacherous pathway. And that treacherous pathway is an outer membrane that is very impermeable, so you need porins, so proteins in the outer membrane, to be able to pass that. And then you have to avoid, like, snipers that are the beta-lactamases that are going to destroy the molecule, and finally bind that to the target. But you have other things like pumps that extrude that drug from that periplasmic space. So imagine these organisms in a tissue. So the antibiotic has to get to the bloodstream, get to the tissue, pass all the membranes, and get to that particular niche to be able to be effective, right? So every single component in a critical ill who is in septic shock with a nasty gram-negative bacteremia becomes critical. How you do the drug, what dose you use it, where the infection is, have you drained the inoculum, that all becomes absolutely critical for a successful treatment of these infections. But in the moment that these organisms become resistant to the antibiotic, almost 80% of the fight is lost because the drug won't work. And if the patient is critically ill, means it's overcome the immune system and the patient is in risk of demising. So we are in the middle of the pandemic, or hopefully getting out of this. We know this is a virus and we identify it. But the organisms that actually cause these infections are not in the air, are probably transmitted in different ways. Most importantly, they become residents of the microbiome of our own patients. So this is an example. We just, 2 years ago, we published this paper in a big national consortium. And this is a phylogenetic tree. So people who are not familiar with this is like a clock The closer these lines are, that means each line represents an organism, so they are closely related. The farther they are, the less related they are. So this ring in red means that all these organisms are related, and usually there are certain genetic backgrounds that produce these epidemics. In this case, in red is the one that we call the 258 genetic lineage of Klebsiella pneumoniae that are carbapenem resistant. But I want to get you this attention to this yellow or orange sort of color there. There are a group of organisms closely related, and all these organisms belong to Houston, Texas. So here in Houston, Texas, is the only major country in the United States where we have an independent epidemic of two genetic lineages of carbapenem-resistant Klebsiella pneumoniae. Actually, Dr. Musser, almost 10 years ago, identified this in this hospital that are circulating in our patient. And it's not only in this is the largest medical center of the world. So we are a hotbed for antimicrobial resistant and superbugs. We have people coming from different parts of the world, particularly South America, Central America. So we are seeing these things all the time. An example, as a clinical talk, this is a patient that is relatively healthy, diabetic, comes with blurred vision, fever, epigastric tens, and nausea, and she can see on the left eye. She has this enormous hepatic abscess, and she has endophthalmitis, septic shock in the ICU, and critically ill. The blood cultures eventually showed this, an organism in the bloodstream causing that. This is a common of these Klebsiellas that are circulating, very aggressive, hypervirulent Klebsiellas. These are the antibiotics that you may recognize. I'm telling you, what is red is bad, what is blue is okay. But blue is only like bad antibiotics, colistin, that basically is almost giving water for that because it's not very good, and these new drugs that I'm talking about. But the drugs that we are common to, the cephalosporins, the carbapenems, the quinolones, aminoglycosides, they are all resistant to this organism. So this is the case in a patient that is relatively healthy with very few risk factors. Imagine the ones that we tend to see. So the first thing I want to recognize is that there are the different flavors. So I'm going to take that Klebsiella and I'm going to divide it in different parts. So the first phenotype that we tend to see here is these Klebsiellas that are resistant to third-generation cephalosporins, but susceptible to the carbapenems. And this is actually done in England. Usually they do the antibiogram, so they report, for example, combination with inhibitor of beta-lactamases. So this typical antibiogram is the famous extended spectrum beta-lactamases that has this enzyme that we recognize called CTX-M15. So what are the recommendations to treat those? So the IDSA just published this, Infectious Disease Society, which was a board of directors of this society, and they divided in urinary focus and non-urinary focus. But you see, if you have an ESBL, you have the carbapenems, ciprofloxacin, levofloxacin, or trimethoprim sulfamethoxazole, if you really can use that and they are susceptible. Because they have high concentration in the urine, and there is a really bone of research. If you start with a carbapenem and then you don't have to use that, because if you lose that drug, you can transition to other drug, transition to other agents if the susceptibilities allow. The one option is daily aminoglycosides that I never use. One of these drugs called plasmamycin, one of the new aminoglycosides, could be an option which is less nephrotoxic. The problem is when these infections, like the patient I told you about, are outside of the urinary tract, so very sick patients. In this case, we actually have data. And it's interesting because in most of these situations, we are in a sort of data-free zone. Okay? So it's very important to think about the randomized clinical trials to determine what's the best therapies for this do not exist. yet, or are very limited. And that's something that needs to be fixed, and we're trying to fix it as much as we can. But there is this study, some of the ESBLs are resistant to carbapenems, but the antibiogram sometimes shows susceptibility to, for example, piperacillin tazobactam, which is a very common drug that people use. And so outside of the urinary tract, this is a trial called the Merino Trial that tested that hypothesis to give ceftriaxone, piperacillin tazobactam, or a carbapenem against the ceftriaxone-resistant Klebsiella pneumoniae. This clearly showed, and I'm not going to show you all the data for time, that the carbapenem was a better choice, and the piperacillin tazobactam was inferior to the carbapenems for this type of infections. So the recommendations is outside of the urinary tract, a carbapenem is the drug of choice. Other drugs may be considered susceptibility, but that's definitely in a clinical trial. And this is important because you saw about 2 weeks ago, we are going to have very soon the availability for an oral carbapenem. This is probably not going to be something that you in ICU are going to use, but those are things that we are facing all the time in outpatient setting and even in patient setting of ESBL producing mildly borderline complicated urinary tract infections and patients with different comorbidities, and we don't really know how to treat a person to put the patient on an IV therapy for a certain number of times. So this drug is called Tabipanem, is produced by a company in Boston called Sphero Pharmaceuticals. This is the comparison of the trial between ertapenem, which is a drug of choice for these cases, versus tebipenem. As you see, the forest plots show there is no statistical significance, so the non-inferiority achieved for an oral carbapenem. And imagine you using an oral carbapenem, what's going to happen with all these bugs in our microbiome when you do it. So there are studies, and we will be one of the sites to try to study this regimen. But that's another option that is going to become important. Another sort of ESBL-like type of organisms that we have to deal to is the ones that produces these enzymes, these enzymes that destroy the beta-lactams, and that we call AMC beta-lactamases. And this is a mnemonic that I use with my fellows as students. So different from the E. coli Klebsiella that I told you about, these organisms have a chromosomal gene naturally that only when the exposure of the antibiotic, they start producing these in high amounts and produces resistant problems. The most common that do that during therapy is Citrobacter, for example, Morganella, Enterobacter, and Serratia. So those are called high-risk Enterobacterales. That's why it's so important our work with the clinical laboratory to identify the organisms and potentially the mechanism of resistance. For these drugs, what happens is that in normal circumstances, this gene called AMC is repressed by the normal metabolism of the cell wall, but in the presence of the antibiotic, these alterations of cell wall synthesis alters this repression, making the enzymes producing high amounts, again in this periplasmic space, destroying the carbapenems. And basically, the beta-lactams. Which beta-lactams are more able to be stable is going to depend how you do and what beta-lactam you use. For these organisms, particularly, the recommendation is of all the cephalospore, all the beta-lactams, cefepime is the most stable for this. Particularly, the MICs are low, but the MICs continue to be high. A carbapenem is also indicated. So again, if we cannot use a carbapenem as cephalosporin, like cefepime may be okay in this organism. The next type of, so we just saw the ESBL, are the carbapenem-resistant organisms. So I told you about that carbapenem, it was the drug of choice in these two organisms, but this is the typical antibiogram of a Klebsiella pneumonia producing a carbapenemase with high MICs for the carbapenems, in this case meropenem, ertapenem. The enzyme that more circulates here in Houston based on that studies is that called KPC, or Klebsiella carbapenemases. This is another recent study from the same group that we just published. The epidemiology of this carbapenem resistance differs in regions and which kind of enzyme actually circulates. So these are enzymes that are very well evolved to destroy the carbapenem, and they can accumulate in that space that I showed you about before. So as you can see, China, South America, United States, Australia, more than 88% of these Klebsiellas had carbapenemase, but the type of access to antibiotics, the mortality of these patients was different. This is a typical analysis that we call desirability of outcome ranking, and in this portion is the mortality. You see how the mortality in South America, some of the sites that we have some research units is very high because they don't have access to the drugs I'm about to tell you in a minute. So the epidemiology, local epidemiology and global epidemiology is clearly to understand what sort of choices we have. And for that, I need to ask you to remember that these carbapenemases are a variety of enzymes that bacteria have evolved. And the main mechanisms of action that we are now discovering new drugs is inhibiting these enzymes. These enzymes are divided in 4 major groups. One that we call A, C, and D that basically have a serine in the active site, and that is the way they destroy the beta-lactam. And the class B that I'm going to tell you later, very important, that have a zinc instead of a serine. And this is important because the pattern of inhibition of this enzyme differs. So drugs that now we are having in our armamentarium are targeted to the specific enzymes. And we need to understand what kind of mechanism an enzyme is present to deploy these drugs. So this, for example, is a Klebsiella pneumoniae. You can see it has low MICs to the cephalosporins, low MICs to the carbapenems, and you can see, well, you may be able to use meropenem. Well, this organism carries an enzyme called OXA48, which is a carbapenemase, but it's not as efficient, and this is a class A as the others. So it may look susceptible, but this patient, particularly in high inoculum infections, tend to fail. So the antibiogram becomes clearly. And then in this case, for example, you have then the contrary, a very high MICs to the carbapenems and cephalosporins. And this is clearly a metalloenzyme we'll call NDM or New Delhi beta-lactamases. So all these enzymes are absolutely crucial to understand where they are in which organism, because these are the new drugs that we have now to treat these gram-negative infections. So they are mostly inhibitors of beta-lactamases that are divided in 2 classes. One, that this is a new non-beta-lactamase inhibitor called DBOs, and it's called avibactam, that is paired with ceftazidime. The other one is relebactam, that is paired with imipenem. And the other one is vaborbactam, which is a different class from those, which is a boronic acid moiety, and is paired with meropenem and called meropenem vaborbactam. And the other drug that we have now available is a new class of cephalosporins called cefiderocol, which is, you can talk about the 5th generation cephalosporins. This drug actually has a catechol moiety there that tricks bacteria to think that they are transporting iron, and this drug is transported to that periplasmic space in high amounts to just destroy the drugs. So these are currently the drugs that all of them approved and the most successful for treating the most resistant gram-negative called carbapenem-resistant Enterobacterales, Pseudomonas, and not Acinetobacter or Steno. So that, how you're going to deploy it, I don't really have the time to do it, but when you understand what kind of enzyme, I can tell you that all these drugs are good for the enzymes that mostly circulate in Houston, Texas, but maybe not that are prevalent in India, like the metalloenzymes. These metalloenzymes that I just showed you about, we cannot really use those, but they are actually inhibited by a strionam. And I wanted to tell you how understanding the mechanisms have become important. We have a patient like this, in which it became with a multi-drug resistant, carbapenem resistant Enterobacterales. And we understood that he had an antibiogram that had high MICs to the carbapenems. In the lab, we were able to identify rapidly, sequencing this organism, that this organism had this metalloenzyme called NDM beta-lactamase. This is the structure, this is the zinc that I told you about, and this is actually inhibited by aztreonam. However, aztreonam alone, because there are other mechanisms of resistance, is destroyed. What we did is to combine ceftazidime avibactam, which is one of the inhibitors of other enzymes, and aztreonam, which is a particular good inhibitor of the metalloenzyme. As you can see here in the lab, how if you put aztreonam alone, this is a Petri dish, this is an aztreonam E-test, so you usually see a halo inhibition here. You see bacteria here growing to the top of the disc, but when you combine with avibactam, you see a clear halo inhibition, and that's the combination that we use against the patient. Patient did well, get out of the ICU, and was able to, the infection could be cured. So there are no clinical trials with this. There are clinical data that are very limited, but based on observation in the lab, we can translate this to our patients. So apart from the carbapenems and the beta-lactamase inhibitors that I just showed you about, the other new drugs that we have is derivatives of new tetracyclines. There are 3 of those that now we are available in this country: tigecycline, eravacycline, and omadacycline. And I can tell you that the most common use for gram-negative infections are these 2, tigecycline and eravacycline. And these are approved for soft tissue infection, intra-abdominal infection, and this in particular for pneumonia. And this is eravacycline mostly for intra-abdominal infections. These are active against most of gram-negative bacteria, including Acinetobacter and Stentrophomonas, but not for Pseudomonas, which is a completely different animal. But these drugs have very low penetration, low blood concentrations. They are concentrated particularly in intra-abdominal tissues in a very high manner. And this is drugs that are helping us to take off the pressure for the carbapenems as an option to treat these difficult organisms. So to conclude, I'm going to give you another case example. Here in the medical center, this is one of my younger faculty, William Miller. He treated this patient, typical patient in the medical center, 60-year-old woman with transitional cell bladder carcinoma. Again, 32 days in the hospital with different infections, all these antibiotic cultures come back with a multi-drug resistant Pseudomonas resistant to here. The patient has received multiple different antibiotics and has a new episode of infection. And again, another organism. In this case, again, red is really bad. Here is the black that is a little bit better. These are drugs that are not very useful. Most interestingly, the drugs I told you about, like ceftazidime avibactam, meropenem bevactam, already resistant. So what do you do with these organisms? So in this case, in case of Pseudomonas aeruginosa, the complexities of the mechanism of resistance are major, like different beta-lactamases that have a capability to destroy cephalosporins and carbapenemases, major impermeability problems, so the drugs don't come there. So Pseudomonas are becoming a really difficult organism to treat. So in this case, the recommendations is, for example, if you have an organism that is susceptible to anti-pseudomonal agents that are shown there, either piperacillin tazobactam, ceftazidime, cefepime, or aztreonam, you may use them. However, one of the important circumstances in which pharmacokinetic modalities seem to make an effect is that when you use high-dose induced beta-lactam, that this is a strategy that we're implementing in all ICUs here at Houston Methodist, because this parameter of concentration above the MIC for a prolonged period of time seems to make a difference in these patients. Although clinical data are still not robust enough to really recommend the routinary. And for moderate severe disease, eventually all the drugs that I mentioned to you And one thing that I want to emphasize is that the combination therapy that is very popular is not really recommended unless there is no other option. And the best antibiotics is the one that works. Easy susceptibility permits this is a way to do it. In the patient that we had, we used the combination again of ceftazidime, avibactam plus aztreonam because we identified a GES enzyme which was not predicted to be there, but thanks to our rapid diagnosis and genome sequencing, we could identify the mechanisms and do the patient. This is another option that is coming called durlobactam, sulbactam against Acinetobacter. So sulbactam has intrinsic activity we're using with ampicillin, but here this is sulbactam, intrinsic activity against PVP of Acinetobacter, and this is a new beta-lactamase inhibitor. The clinical trial has concluded, at least in a press release, appears to be effective. So this is a new drug for multi-drug resistant Acinetobacter, which is one of the most difficult bugs to treat. In summary, I have walked you with different mechanisms of resistance. You see here, I'm trying to depict the different drugs that I just mentioned to you before, green, red, or yellow, how they will be used. This is complex. This is difficult. This is why infectious diseases is with you all the time. So the message here is consult infectious diseases, right? We will help you to do that, and this is the reason I give in this talk, to understand the complexities of these organisms. But the good news is that we have new drugs, that we can deploy new strategies. Another interesting strategy that we are starting to use here in our vulnerable patients is phage therapy. So we have we pair with our colleagues at Baylor College of Medicine, and we are able to basically train phages to particular strains that infect our patients in the most desperate cases. These are very important, small case report, but this is getting some traction. But we have now a setup that would allow to deploy phages in very difficult patients, for example, LVAD patients and all that, infected with multi-drug resistant organisms. So this is another exciting development that we hope to bring here to Houston Methodist on a routine basis. In summary, I've shown you how complex this situation is, how this pandemic is killing our patients, how difficult it is to work without antibiotics, and understanding this basic mechanism of resistance and how that allows you to get to what I call personalized medicine in infectious diseases, because there is no other way. It's like cancer. You devise treatment for a particular tumor. We need to devise treatment to a particular bug in a particular patient. These new compounds against multi-drug resistant organisms are here. We need to deploy them. We need to use them. We need to protect them, and particularly be very aware of this situation and call our expertise every time is needed. I'm the editor-in-chief of this journal, and we do a podcast with different kind of topics. There's a topic on phages if you want to go. It's called Editors in Conversation. And there is in the page there are challenging clinical cases for trainees to understand how to dissect a case with resistance, to go to the mechanism eventually to how you treat the patient with an expert commentary. So I invite you to do that. I also want to thank some of the work that we presented and the grants that funded this, particularly the Antimicrobial Resistant Leadership Group in IAID, which we are part of it. Thank you very much for your attention, and I don't know if there is time for some questions.
Thank you, Dr. Arias, for that very illuminating presentation. Does the audience have any questions? I think there's one up there, Dr. Arias. Does Houston Methodist Lab report in EPIC the presence of a metalloproteinase with culture and sensitivity results?
So there are molecular tests available once the organism is identified that basically are targeted against specific genes that code for the metalloenzymes or the normal carbapenemases. So yes, all these normally are reported. In general, in Houston Methodist, they are reported in most of the carbapenem-resistant organisms coming from different cultures. The problem with that is the mechanisms of resistance sometimes are not identified, and that's what we're trying to deploy now, a genomic approach for ICU patients where we can have whole genome sequences available to understand and interpret all the phenotypic and then design specific combinations for patients or specific antibiotics for patients that are treated here.
Thank you. I actually was going to ask you, is that available in real time, the genomic sequencing while the patient's in the ICU?
Not yet. We actually finally got the machine about 2 weeks ago, and we are in the process of IRB and all that to be able to deploy that. I'm hoping by the end of the year we will have a very robust genomic enterprise here, that we will know about the circulation of all the organisms, what kind of phylogenomics we have in each unit in our hospital.
Excellent. And you know, the other question I had was, with the knowledge of the antimicrobial resistance, is that a segue to help us design new drugs? Is that what leads to this?
Absolutely. So you saw the explosion on this class of drugs called beta-lactamase inhibitors. And that comes from a very deep dive into the structure and biochemical structure and function of these enzymes, right? There are several other drugs in the pipeline to trying to inhibit efflux pumps, for example, try to increase porine production. We are trying to alter how the bacteria evolves with our own molecules. So there are several cool approaches, but to get there as a drug, we have a long way to go.
Okay. Any other questions from the audience? Otherwise, I'm very thankful to you, Dr. Arias, for coming up here.
Thank you very much.
Thank you very much.
Thank you very much.
So we've come up to our break. So take the time to stretch your legs, move about. There are some refreshments in the boardroom. And please remember to visit with the exhibitors. And don't forget to look at the abstracts. Please come back by 5:10 Central Standard Time. Thank you. This is for the... Welcome back. I hope everyone is enjoying the program today. And as we move into the evening session, let's continue with our next presentation. Now, for something different, I think you'll get a lot out of this. A panel discussion of two with scenario questions posed by our very own Dr. Deepa Gator and answers provided by our expert guest speaker, Dr. Carla Seven, who's joining us from Nashville, Tennessee. The topic to be discussed will be post-intensive care syndrome and long-haul COVID. Dr. Carla Seven is an associate professor of medicine at Vanderbilt University Medical Center in Nashville, Tennessee. She's a specialist in pulmonary and critical care medicine. Her areas of interest include the care of patients after critical illness. Since 2011, she has led the development and implementation of ICU Recovery Center at Vanderbilt. She has worked extensively to promote the awareness, research efforts, and education about post-intensive care syndrome through Society of Critical Care Medicine's Thrive Task Force. Joining Dr. Carla Seven is Dr. Deepa Gator, who is an associate professor of clinical medicine at Weill Cornell and the program director of our Pulmonary Critical Care Fellowship at Houston Methodist Academic Institute. Dr. Gatour is very active in research and is the PI in multiple clinical trials. She also serves on the editorial board of CHEST. Her areas of expertise include sepsis, COVID-19, ARDS, and cytokine release syndrome. Detailed bios of both Dr. Seven and Dr. Gatour are available on our symposium website. Please welcome Dr. Carla Seven and Dr. Deepa Gatour.
Thank you so much for the wonderful introduction, Dr. Dalla, and nice to virtually meet you, Dr. Seven. We hope next time we can have you here in Houston. So in the next 40 minutes or so, Dr. Seven and we will be talking about post-intensive care syndrome as well as long-haul COVID. And I will be introducing 3 scenarios, 2 of which are my very own patients, seen here at Houston Methodist Hospital. The main objectives of today's talk is to understand the short and long-term morbidity of post-intensive care syndrome, to understand the extent of long-haul COVID, as well as to learn about instituting an ICU recovery program in a tertiary care center. So let's meet our first patient. She is a 45-year-old previously healthy female. She was admitted to our medical ICU with a fever of 103. She had bacteremia and septic shock. She was emergently intubated in the emergency room and sent to us to the medical ICU, and where she spent a prolonged ICU length of time, almost 12 days. And during the course of time, she had required to be on sedation, she had required to be on neuromuscular blockade, and was intubated, of course, due to severe ARDS. She was also about to get, she was on an ECMO watch because her ARDS was quite severe. But somehow, she got better. She had AKI at presentation. She had required CRRT as well, and AKI resolved. She got better. She did have multiple episodes of delirium for which she needed on and off sedation, and then she got better. And we were very proud to have, got her better into such a state that she was extubatable, and we patted ourselves on the back, and then we sent her off. And then I actually kept in touch with her over the next several months, and she was having multiple symptoms even after she left the hospital. She was discharged home, and this is one of our success stories. And yet she had so many morbidities or so many symptoms. And I don't want to talk about her symptoms, but what I did was we called her back to our sepsis symposium, and we did a live interview of her and about her symptoms. And so I would like to share what she actually told me that day.
When I woke from the coma, I didn't realize that I just couldn't get up and go to the bathroom. And after I discovered that my legs weren't working and I was not going to get up to go to the bathroom, I think that was the moment it hit me that the impact of sepsis, that I'd have to learn how to sit up and not fall over. I'd have to learn how to feed myself. I'd have to learn how to walk. And so I had some physical therapy in the hospital, and I left the hospital with a walker. But in terms of me really being able to get around in my house, my husband has a physical disability, and my house is already set up. So I didn't really have any problems managing myself, but he had to teach me how to manage getting myself in and out of the bathtub, things that I take for granted because I walk all the time. So it was very helpful. And in terms of getting support at home, from the time I was in the hospital until probably about a month after I left, the hospital, there was someone with me 24 hours a day. I was never alone. I was always a family member or a friend, using my husband's spare wheelchair to get around when I was feeling very weak. But I just basically threw myself back into as many activities as I could once I was released. I noticed I couldn't drive. I was having a lot of tremors, and I think it was because of the medication that I was given. And I didn't really start driving until like maybe June. My mom wanted me to order a pizza because I think I had like my little nieces over. And typically I would just get on my phone online and just order pizza. And for some reason I was just so frustrated that I couldn't do that. And I became very anxious and angry. And so I just said, I can't do it. And my mother looked at me like, are you okay? Right? Because that's what I typically do. So I just picked up the phone and just called old school, picked up the phone, ordered the pizza. And then I became a bit alarmed. I said, okay, is this how it's going to be? Is this how my brain is going to continue to operate, where I can't handle something that simple? I mean, I had to go back into an executive role at work, and I can't order a pizza online. So another thing really is what to expect after sepsis, like with my body, like the things that I didn't expect. Like I lost cups and cups and cups of hair. I thought I was going to end up being bald. And I wasn't sure if it was going to grow back. I really didn't know what to expect. And no, I didn't understand that might happen to my body. But thank God my hair started growing back. It's not as thick as it was, but it grew back. Some of the cognitive issues, like, I was explaining about the ordering the pizza, tremors from the medications. I mean, but in terms of like what I might be dealing with ongoingly, I don't know, because I start work on Monday, so I don't really know what I might encounter in terms of, am I going to be able to do some of the things that I did previously? Time will tell us that. When I offer.
So you've all heard my patient's physical as well as cognitive disability. I'm going to hand it over to Dr. Seven, who's our expert here, to kind of break it down and give us more insight on the post-intensive care syndrome.
Thank you, Dr. Couture, and thank you, Houston Methodist. It's so great to be here with you today, if only virtually. But I love this video, and when Deepa first sent it to me, I thought this patient really encapsulates so many aspects of what we now know of as the post-intensive care syndrome. And if you haven't heard of this yet, I hope you have, but it's characterized by physical impairments, like she talks about muscle weakness and loss, critical illness, neuropathies, and often long-term decrements in pulmonary function. She also mentioned a couple of things that are very disturbing to patients, but are relatively benign, like hair loss. Cognitive impairments, prominently deficits in executive function, which you need to order a pizza online or go back to work in your job, regardless of what your role is there. And there is also slowness of mental processing speed, issues with visuospatial relations that really affects things like driving, for example, and deficits in memory and attention. And then we see a lot of mental health problems in this population. Many of patients who are early post-hospital will exhibit prominent anxiety and PTSD, which we'll talk about a little bit more, and depression. The families of these patients, this patient's family obviously was very supportive, and she had a lot of help. Her husband, as she said, had some physical disabilities, so they were really prepared to take care of somebody who needed a wheelchair or assistance. But families are not exempt from the stressors of a critical illness in the recovery period, so we see increased rates of depression, anxiety, and PTSD in families as well. And all of these problems work together to result in a high burden of chronic health conditions, including increased mortality in the year after a critical illness, increased healthcare utilization, increased incidence of the development of new chronic health conditions that you wouldn't necessarily think were related to the critical illness, including diabetes, hypertension, and COPD. And we started a post-ICU clinic in 2011 and 12 to try to target some of these problems. As Dr. Couture mentioned, this was one of her wins, one of her super survivors, as we sometimes call them, and yet they had so many problems that needed addressing, and there was really no place for them to be addressed. The physical sequelae, again, are quite prominent. We as medical doctors often feel most comfortable with the physical sequelae. This is a patient who was in our ICU for 4 months, and he came back to our follow-up clinic having lost 128 pounds from baseline. A lot of that was muscle mass, as you can imagine. Our mean sort of typical weight loss is about 26 pounds from baseline by the time we see folks back in clinic. He wasn't walking. He's in a wheelchair. He's got some braces to help with his critical illness polyneuropathy, which you can't really see, and he's still got a bunch of surgical drains and things like that. And this is one of our nurse practitioners, Sarah Bloom. This picture was in a little local news reporting, so not exploiting any HIPAA laws, hopefully. But I just wanted to bring this to your attention because the patient mentioned it, and so many of our patients will mention hair loss or alopecia. That can be diffuse hair thinning, or as in this patient, more focal hair loss, especially at areas where there was a lot of friction. You can see that he had a pressure ulcer in the back of his head here, and the hair is growing back kind of weird there. And onychomedisis, which is this nail changes that looks like you have a second nail growing over your first nail. Sometimes it's just a line, which is really a marker of the physiologic stress that a patient experiences when they experience a critical illness, and the nail kind of just stops growing and then it starts growing kind of differently. I even had a patient today in clinic asking me about this. So it's actually a well-known phenomenon and something that you can tell your patients is benign and self-limited. But cognition is a part of the post-ICU syndrome that I think a lot of ICU doctors feel less comfortable with, and it's also not as obvious as the physical dysfunction. So you have to actually actively screen for abnormal cognition in ICU survivors. In many cases, they will not be aware of their own deficits, and especially previously high-functioning people may seem very they're able to compensate for their deficits, and so that's where formal screening comes in handy. This is data from a study that came out in 2013 already, which is now almost 10 years ago. I find this a very scary slide, actually, because it looks at cognition scores as measured by the R bands in patients who survived a critical illness. And these are all patients with medical critical illness, so not people who had primary brain injuries or strokes or direct hits to the brain. And you can see that normal is up here in the green line, and by these box and whisker plots, you can see most of our patients are somewhere between mild cognitive impairment, which is the orange line here, and Alzheimer's disease, which is the blue line. Traumatic brain injury is this little purple dotted line here in the middle. And these deficits persisted out to 12 months in all age groups. And the especially disruptive part, I think, is that being young, in this left-hand column, younger than 49 years, did not protect you from these cognitive impairments. If you're wondering which of your patients are going to develop cognitive impairment after the ICU, delirium is the strongest independent predictor of cognitive impairment. So patients who are delirious in the ICU, which is probably most of our patients who are critically ill enough to be mechanically ventilated at one point or another. And while we have been rightly fixated on improving our care in the ICU and improving ICU care, including careful implementation of the A to F bundle, which helps us diminish some of the impacts of these long-term outcomes, as soon as patients leave the ICU and go to the ward, we kind of lose sight of them a little bit. Maybe we're checking in their chart to see how they're doing. But by the time they're preparing for discharge to home, we're not part of their care team anymore. And the opportunity to provide some anticipatory guidance, as this lady asked for, I don't know what to expect after an episode of sepsis or septic shock, for example, is not there for us. And that is, even the ward preparation is better than what patients get when they leave the hospital. And so attention to early home adjustment with many new impairments or late community adjustment when they're trying to adapt and get back to work, for example, is just not in place. And this leads to many patients feeling this stark drop-off in care from the very intensive care they received in the ICU to basically nothing in the outpatient setting, which is really a huge gap in our care, I think depicted very well in this. I'm not sure this is exactly what she was trying to depict, but I have two pieces of art in this presentation by Nancy Andrews, who is a wonderful artist who suffered a critical illness herself and did a wonderful series of drawings and collages depicting her experiences with ICU delirium and recovery. Dr. Couture.
Thank you. So moving on to our next case scenario, again, also our patient, a 56-year-old male. He was the second patient admitted with COVID infection to our medical ICU, and he also suffered a prolonged ARDS course. He received prone ventilation. He was on vasoactive medications. He was on neuromuscular blockade for a prolonged period of time. I mean, not just the 48 hours, but had to be on prolonged neuromuscular blockade as well. He also had, because of these reasons, had like obviously late mobility in the ICU. I know we all, propose that every patient, we have to initiate early mobility in the ICU, but again, late mobility because of all these reasons. And in addition, because of the COVID pandemic and because of the state of affairs at that time, there was no family visitation for him. We did have a virtual visitation, and this was way back in March in 2020. And again, also I kept in touch with him just to kind of see how he's been doing. And he also had very strenuous course in terms of he had to call back his physician multiple times about multiple issues like joint pains and nightmares. And again, I don't want to take away the words from his own mouth, and we have recorded his journey as well, after his ICU recovery, and here it is.
When I was discharged, I had a lot of PTSD. I had a lot of mental issues as far as thinking that I was going to have to go back because I was still laboring with my breath. So I had a infection that kept happening in my left leg, in my calf, and it would go away. She would give me an antibiotic for it, and it would come back again. Couldn't sleep. So I was constantly calling Dr. Hart and asking her about medicine to be able to sleep, or for medicine for my joint pain or anything like that. And because of the COVID situation, you couldn't go in. Everything was remote. 2.5 since I've had COVID. And physically, I'm about 85% of where I was before. And I would say 85% because I still have problems with the laboring with my lungs sometimes. I get a little tired. Whereas before I wouldn't be so tired. I get a little tired, and I couldn't answer the phone, anything for myself except go to the restroom. I could not hold a cup of water in my left hand. I couldn't raise it above my head. When I was able to put 75 over my head before, and I had a lot of nightmares, and I couldn't make faces. It's like I put faces on people. I guess that was my body kind of telling me or kind of making it okay because I wasn't able to walk. That bothered me. I couldn't raise my arm by myself. I lost a lot of my physical strength. My joints still bother me. See someone without a mask, I feel nervous, and I have to deal with that. That's where the anxiety, the PTSD comes from. So I'm dealing with that on a day-to-day basis now.
So you heard
So,
our patient talking about not just the symptoms of post-COVID, but also intermixed with that, symptoms of post-intensive care syndrome as well. Over to you, Dr. Seven.
Yeah, such a great summary, I think, of many of the issues that our patients deal with. And I just want to emphasize that nothing that either one of these patients has said is at all out of the norm. I think if you see patients back after a critical illness, you will see that more patients than not are having these problems without any specific care program to help them with them. And PTSD is a significant component of the post-intensive care syndrome. So this is from a meta-analysis that was done pre-COVID, which suggested that PTSD symptoms were present in at least 1 out of 5 post-ICU survivors. They were more likely to occur if you had a comorbid psychopathology. So if you have pre-existing anxiety, for example, or PTSD, those things are not going to be better after you have a critical illness. Although it's been very interesting to talk to some patients who had pre-existing PTSD, and we've had patients have PTSD from war trauma, for example, and tell us that their PTSD from being in the critical care unit is worse, which is not a good commentary on the ICU. Benzodiazepines, which we had really gotten away from using very frequently pre-COVID in response to some data suggesting that it increases not only post-traumatic stress, but also mortality. We ran out of some of our medicines during COVID, obviously, so that was something that more patients were getting. And then early memories of frightening ICU experiences, awake intubation, chest tube in the field. One could argue that developing COVID during a global respiratory pandemic where people are dying from COVID in great numbers is an early memory of a frightening ICU experience. All of these things are risk factors for post-traumatic stress. And having post-traumatic stress symptoms after a critical illness not only affects your mind, but also, as this study in cardiac arrest survivors shows, may affect your lifespan. This is a study out of New York done by Sachin Agarwal and colleagues that looked at post-traumatic stress symptoms after a cardiac arrest. And patients who had post-traumatic stress symptoms, depicted here in the red with the pink error bars, versus those who did not have post-traumatic stress symptoms, those who had them were more likely to die of a cardiac etiology in the year following discharge. So very important thing for us to screen for and treat. Anecdotally, we think that some of the early anxiety that we see post-ICU may develop into PTSD and is a potential place for us to intervene, although that's not been shown yet. Unfortunately, and this is data that just came out last year, on the extreme end of PTSD, depression and anxiety in ICU survivors is markedly elevated of suicide, risk of suicide and self-harm, more than double that of the general non-ICU hospitalized population. So what did COVID bring to the table for ICU recovery? As I mentioned, we had patients who had increased use of benzodiazepines, but we just also had really more sedation in general. The patients who have had COVID ARDS, for example, have been very, very hypoxic and were often deeply sedated in order to ventilate them. The vent times were very long, more use of neuromuscular blockade. So obviously, if you're deeply sedated and paralyzed, you are not getting early mobility therapy, as mentioned in this patient. Decreased family visitation has had a huge impact on sedation and post-traumatic stress and patients' understanding of their ICU care. And of course, our resources and our staff were extremely stretched, so we weren't able to do many of the things that we considered to be optimal ICU care. I put in the parentheses down here, misinformation and distrust of the medical establishment, because that certainly made our job a lot harder in the latter part of the pandemic. But I think the pandemic has also brought to light a lot of the issues that have been plaguing non-COVID ICU survivors for many years, and I think brought to the fore the concept that we need to build care systems to care for the long-term consequences of a critical illness. On the right hand, I just have a visual for you. This is a study by Biren Kamdar, who did his residency here at Vanderbilt and then went out to Hopkins where he did this study, and he's now at UCSD. But this is an actigraph study of a normal control in the A panel over a 24-hour epoch. And in the B panel here, this is the combined data from 24 ICU patients over the same time period, same scale. And you can just see that our patients are not moving in the ICU. So it should be no surprise to us that they're extremely weak and debilitated after even a few days of critical illness. Again, this was pre-COVID. So pretty soon after patients started developing COVID, the concept of long COVID or persistent symptoms after COVID, and a related term called PASC, post-acute sequelae of COVID, came into the general consciousness. And this is a nice paper that was in Nature Medicine last year, looking at sort of the time course of when people have acute COVID and then some of the things we're seeing post-acute COVID. And, the things that I've circled here in orange, you can see are quite commonly invoked: shortness of breath, cough, persistent oxygen requirement. I see a lot of these in my general pulmonary clinic. Thromboembolism, something that we're very afraid of both during and after COVID. But you can see highlighted by the blue arrows, muscular weakness, anxiety and depression, sleep disturbance, as this patient mentioned, post-traumatic stress, cognitive disturbances or brain fog, hair loss, which we've already talked about. All of these things, all of these issues very familiar to us from pre-COVID, post-ICU clinic. So there's probably some overlap between long COVID and post-intensive care syndrome, or PICS. The World Health Organization came out with this definition of long COVID in October, which I think is very helpful in that it identifies long COVID as a history of COVID and persistent symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Most of my patients that I see in post-ICU clinic have post-intensive care syndrome plus other things like post-COVID pulmonary fibrosis, et cetera. So they have an alternative diagnosis, and I don't call that long COVID. But we also have very many patients who had relatively mild courses in that they were not hospitalized or on a ventilator, and they have persistent symptoms, which may be consistent with long COVID. So this is a picture. This is not my patient. I found this picture on the internet not too long into the pandemic. This was a patient who's also a nurse who developed COVID quite early in the pandemic and posted this post-COVID critical illness picture of himself on social media, noting that he couldn't even hold his cell phone. It was so heavy. That's how weak he was. And obviously he was very fit before he got sick. And there were many nasty comments about how this patient probably just stopped taking anabolic steroids. But to me, this is a very typical picture of post-intensive care syndrome. He's got marked weight loss as characterized by temporal wasting, for example, shoulder girdle weakness and muscle loss. So when the patient in the video talked about he couldn't even raise his head over his shoulder, and previously he could lift 75 pounds, that's a very common complaint for patients who've been in the ICU because they just don't raise their raise their arm overhead for weeks or months, and lose a lot of, they can develop like almost a frozen shoulder. So that requires a lot of specific physical therapy. He had clearly had a tracheostomy, which has been decannulated, and he still has a PEG tube for enteral feeding, marked weight loss, as I mentioned. So this is not long COVID. This is post-intensive care syndrome. Here's another patient who was featured in a New York Times article about delirium. This was actually one of our patients here at Vanderbilt who agreed to be part of this study, and this news article. And she's so artfully photographed here because unfortunately she had significant scarring on her forehead from pressure injury from proning, which we were not particularly experienced at doing early in the pandemic. But she had a really great physical recovery, but had these persistent cognitive deficits. And as I mentioned previously, the most likely prognostic indicator for that is delirium, which she had. So again, this is not long COVID. This is not brain fog from long COVID. This, I think, is post-intensive care syndrome as well. One last case in this vein. This is a patient who had COVID about 8 months before I saw him. He had not had any COVID-specific therapy. He had not been hospitalized for his COVID. He subsequently got vaccinated. He had a childhood history of asthma, was on no meds for that. Obstructive sleep apnea, was not getting that treated. Had a fall at work and gained 30 pounds after being put on light duty, so he was obese. And he was very short of breath, came into our hospital with a new oxygen requirement. And he actually asked me, do I have long COVID? He had a PE, so that's why he had a new oxygen requirement. He also had untreated asthma, untreated sleep apnea, obesity, and probably deconditioning. So, I told him, let's treat all those 4 or 5 alternative diagnoses and then reevaluate whether long COVID is a label that can apply to you. I suspect not.
So my next scenario is actually a tertiary hospital. I mean, if you think about it, not all centers have post-intensive PICS clinic across the United States or even all over the world. So I'm presenting here sort of example of a tertiary care center which sees really high volumes of ICU patients, about 8,000 ICU patients, 8,000 patients per year, and who also have prolonged hospital length of stay, prolonged ICU stay, with an average of anywhere between 3 to 5 days in the ICU and a long hospitalization course as well. And these patients, they get discharged to other facilities like long-term acute care facilities, skilled nursing facilities. But if you think about it, majority of them, almost half of them, they get discharged home, and that's where I think we have a great role to play in terms of taking care of their PICS syndrome. And yeah, so this is my next scenario. Over to you.
Yeah, so it's a great question, and the question is, should these patients have a specific follow-up? I think we, as intensivists, have suffered a little bit from being a young specialty and not necessarily educating the public that what we provide is subspecialty care and requires subspecialty follow-up. So, for example, this is a patient, looks very dramatic because he's all packaged up for military transport, but a young person with flu, ARDS, who was cannulated for ECMO. And this is a patient who we will, should he survive, send home with no specific instructions except perhaps follow up with your PCP in our area, and I suspect probably in yours as well, fewer and fewer patients have a primary care physician that they can follow up, especially patients who are young and healthy prior to their critical illness. So I like this figure. This is quite a few years old now, but it just shows us how, as we got good at critical care and critical care became an expanding specialty, the data behind what we do in the ICU, this is a dotted line, this solid line is all critical care citations, and this dotted line is randomized controlled trials in all critical care. You can see that we are putting more and more science behind how we take care of patients in the ICU. And we're succeeding. We're discharging more and more patients into the community every year after a critical illness, because more and more patients are surviving, patients who would not have survived 20 or 30 years ago with the same illness. And there has been around the same time period pretty much equal interest in long-term outcomes after critical illness, and yet the randomized controlled type of data to tell us how to improve these outcomes has been lacking. So there are a number of models of post-ICU care that have been proposed in an attempt to address this gap in care. The one that I'm going to talk the most about today is this concept of a multidisciplinary post-ICU clinic. Many of these are in tertiary centers like Vanderbilt. This is our beautiful helipad here. But most patients who are discharged from an ICU will have follow-up with their primary care provider if they have one, or if they have any follow-up. Some patients don't get any follow-up, especially if they don't have primary care in place. Peer support is something I won't really have time to talk about today, but is a wonderful adjunct to a post-ICU clinic, and in many places is a freestanding support for patients who have survived a critical illness, and they get a lot of practical knowledge from other patients and families who've gone through the same experience. And then when we first started looking at post-ICU care, the concept of telemedicine was kind of pie in the sky. And we started doing it just before COVID, and COVID really pushed telemedicine into common practice and a viable option for follow-up of this critically ill and in many cases very disabled patient population who may have trouble getting back to an in-person clinic. So the idea of a post-ICU clinic is not one specific model. The ones that have popped up in the US over the past decade or so are often multidisciplinary because these patients, as we've identified, have a lot of different kinds of problems. Our post-ICU clinic consists of an intensivist, a critical care ICU pharmacist, a neuropsychologist who does screening for depression, anxiety, PTSD, and cognitive dysfunction, a case management arm, and of course we have our respiratory therapists who help us with measuring pulmonary function and 6-minute walk tests, et cetera. But there are a number of barriers to creating such a program. These were outlined by Kimberly Haynes et al. In a series of papers from a study called the Collaborative Assessment of ICU Recovery Needs, or CARN. This was a series of qualitative studies looking at the development of these kinds of programs. And these were some of the barriers that were highlighted. Lack of funding. So if you don't have an ICD-10 code for post-intensive care syndrome, and you don't have a DRG or a correlating funding pathway to care for patients after an ICU stay, like we have, for example, normal pregnancy, labor, delivery, or CABG or surgical DRG, all of those things include pre and post care. We don't have that for medical critical illness yet. Then funding can be an issue. Lack of space. Many centers found trouble finding a recurring space where they could have clinic. Now perhaps something that could be combated by a heavy use of telemedicine. Identifying appropriate patients, which there have been a number of ways to try to screen which patients are going to be most benefited by a multidisciplinary post-ICU clinic. for example, by severity of illness or pre-existing conditions. And patient and family attendance was found to be a barrier, again, I think because in many cases we do not do a good job of educating patients and families as to why they might need to follow up, or even letting them know that such a thing as post-intensive care syndrome or post-ICU problems may exist. There are also quite a few internal barriers to developing this kind of program. These are all things that intensivists have said to me as to why we don't need to have a post-ICU clinic at their particular center. The first one is the belief that, as I too believed before I started seeing patients back after ICU, that my patients were getting better. They were fine and they don't need to come back. Or if they didn't come back, it was because they were fine. Some folks are concerned that they don't know which patients need to come back, and certainly that's an area that could benefit from more investigation. I will tell you that in our center, we're still using the same selection criteria that we just started with in 2011 by guessing sort of severity of illness, mechanical ventilation of any duration, shock of any etiology, or delirium, because we know that those things increase your risk of post-ICU deficits. Some intensivists say, I don't know how to do clinic. This flies, I think, a little bit more in the UK, where many of the intensivists are anesthesiologists. But in the US, a lot of people who do intensive care, of course, you can go through a surgical track or a medicine track or an anesthesia track, but 2 out of those 3 know how to do clinic, and also it's not that hard. It's too expensive. I'm going to show you a little bit of data, and I'm needed in the ICU is in many cases a potentially legitimate argument, but one could also suggest that you're needed in the clinic after the ICU. And then some people just think it's too hard, and that one I can't really argue with. It is hard to start a new program. It is hard to change culture, but as one of my colleagues in the Thrive Task Force said once at one of our meetings, this is a pretty addictive work. Once you start seeing these patients back and learning a lot about post-ICU outcomes, you probably are going to want to keep doing it. So we don't have a lot of data on the financial side, but this is a study that came out of Geisinger, which is a very interesting situation because they have a very comprehensive multidisciplinary post-ICU clinic with a very heavy case management arm. They have a full-time nurse case manager who calls patients like 3 times a week after they leave the hospital. And they do a very thorough behavioral health, neurocognitive, and medical assessment in their post-ICU clinic. And because Geisinger is also an insurance plan, they were able to estimate what sort of cost such a clinic was costing the health system, given the time that the intensivist and the FTE for this nurse case manager, et cetera, was costing them. And this is not a randomized controlled trial, so they were only able to look at the patients that they got to see back in clinic, but were able to estimate an annual cost savings to the health system of somewhere between $250,000 and $420,000. So perhaps even a cost saving program. But there are also barriers, other barriers, for example, on the patient side. These are some of the reasons that our patients have given as to why they will not schedule a post-ICU clinic visit. So this was data that we took down when patients were called to schedule their post-ICU clinic visit and they declined to schedule. Too many doctors. So a lot of patients who leave the ICU will also still have kidney failure, and they see a nephrologist and they see an endocrinologist and they have a primary care doctor and they have too many doctors. Many of our patients, we actually, this was before we started meeting them in the hospital, we would call them after hospital discharge and their contact information was just no longer valid because in some cases, because they were so debilitated that they had changed their living environment. Some were staying with friends. Maybe their contact information was wrong to begin with, but we just couldn't reach them. Transportation or distance to the hospital is obviously a problem if you are at a tertiary center, and then financial barriers. And some of our patients had already died by the time we tried to get them back to clinic. So we have looked at telemedicine as a possible means to overcome some of these barriers. There are certainly advantages and disadvantages, and I think this is a developing area, so stay tuned for more on that. And I just want to say one more potential benefit to hospital systems is the potential to decrease readmissions after critical illness, which we were able to show a trend towards in this randomized pilot study that we did of an ICU recovery program compared to usual care. The program included inpatient as well as outpatient aspects. And so I would just like to leave you with the idea that these patients probably need more than just one thing, and they may need something not only at hospital discharge and at post-discharge follow-up, but even as soon as we think they're going to survive in the ICU is when we should start planning for this recovery trajectory, which may in fact be a very long road. In addition to trying to do something right for the patient, we shouldn't forget that we actually get a lot from doing post-ICU clinic as well. This is another paper from the Cairn study, and really looked at how seeing patients in the post-ICU setting can improve our in-ICU care, which has been a huge part of my practice personally, and I think an area that's ripe for additional investigation. So in summary, following patients post-ICU allows us to learn the natural history of some of these emerging diseases, including post-intensive care syndrome, post-COVID problems, and long COVID, identify and treat post-critical COVID as well as other post-intensive care syndromes, and to take that learning back upstairs to make our ICU care better. And if you're interested in that and you have a post-ICU clinic or a peer support group, we would invite you to join CHIRO, which is the Critical and Acute Illness Recovery Organization. It's a group of really motivated people who are interested in improving survivorship for our ICU survivors. And I will end there and stop my share. Dr. Couture, I don't know if you want to say any final words. Or if you want to take some questions.
Yeah, no, this was an amazing overview, and I mean, I think we are ready to take any questions. So one of the questions from the audience is, how do you differentiate which patients should be followed up in clinic versus those that may not need it? Or do you recommend every patient post-ICU get follow-up in clinic regardless of length of ICU stay?
Yes, great. And if I anticipated that question, which is why my next slide was, can we predict PICS, and what sorts of things would predict PICS, which I'll be happy to share again. But that's going to stop your screen share, but I will do it anyway. Because I think this is a useful thing to look at. This is from the SCCM held an expert consensus conference a couple of years ago to answer this specific question, really, which is, can we identify which patients need help? So there are certainly things, domains before, during, and after critical illness that suggest patients who might need to have more attention. As I mentioned, delirium during the critical illness, sedation, especially with benzodiazepines, these early memories of frightening experiences, and then the physiological parameters that we use here at Vanderbilt, sepsis, shock, being on life support, basically. Again, pre-existing problems do not negate the problems that are going to develop in the ICU. We do exclude patients at Vanderbilt for our post-ICU clinic if they have a life-limiting illness, for example, if they're going home on hospice, or if they have comprehensive multidisciplinary team care from another place, like if they have a transplant, they're getting a lot of attention. And then after critical illness, if there are early symptoms of anxiety, depression, or PTSD, that tends to portend a rockier course. And this paper here, Wawer et al. Attempted to look at some measures at hospital discharge to predict long-term PTSD, for example, with some variable success. But this is a good paper if you want to look at that in more detail. Mark Michelson is the first author, and I was the last author. But so I don't have to screen share again. I'll just tell you that once you get patients to clinic, these are the tools that there was consensus about using. MoCA for cognition screening, the Hospital Anxiety and Depression Scale for anxiety and depression, and then there was more variability about how we should measure physical function or post-traumatic stress, but there are a number of tools that are commonly used.
And thank you. The next question that that one of the audience posted, and also my question, is what do you recommend for someone who wants to start a post-ICU ambulatory clinic in a hospital setting, and how to, for example, like how to get the administrative support, the essential staff, and other services?
Yeah, so very excellent question, and I get that one a lot too. And I think the core criterion, the core ingredient that you need is one ICU type person who really cares about this and wants to see patients back in clinic. So one of my colleagues in Kentucky, Ashley Montgomery Yates, she's an intensivist. She just started the clinic. It was just her. I don't think she even had a tech when she started, and she was a solo practitioner in the post-ICU world for many years, and now she has more help. But you are probably, if you are passionate about this, you're probably not the only one. So ask around and see who might be willing to work with you. Yes, I think that hospitals should support this, but sometimes you need to show your benefit with some volunteer effort at the front end to show, how many patients need this and how many patients you can get back to clinic and what sort of outcomes you can demonstrate from that. So some centers have had some success that way, get a little pilot going and then make yourself indispensable so they can't get rid of the clinic. And then we also do a fair amount of I guess it's multitasking. Our ICU pharmacist, for example, she has been part of the clinic since the beginning, and she doesn't get extra money to come down to clinics. It's just she considers that part of her ICU job. So we do kind of piggyback off some ICU resources, as I think is only fair since the ICU was the source of the issue.
Yeah, I was just looking at Dr. Masood when you said that, but thank you for reiterating it. And the final question is, you spoke about limited mobilization with patients in the ICU and mentioned physical therapy. Do you also use occupational therapy as well to mobilize patients during their ADLs?
Yes, physical therapy, occupational therapy, speech therapy are only three of the therapies that we really lean on heavily. And in our center, our physical therapists and occupational therapists work together in most cases as a team. And many of our patients will go home with some kind of physical and occupational therapy in the outpatient setting. There are clinics that have physical and occupational therapists in the clinic with them, which is so fantastic, and I think a wonderful addition. UPMC, for example, they have an agreement with their rehab hospital, which is adjacent to their clinic. So they donated some therapists to screen patients in clinic and then bring them over to the rehab hospital. So, when you're looking at what sorts of resources you have for your clinic, you also have to look at your local strengths. So for them, that was a local strength. For me, I couldn't, our PT and OT folks were already so stretched and understaffed upstairs that I couldn't convince them to let me borrow a half day a week. And likewise, not everybody has a neuropsychologist like I have, which is a huge luxury. Dr. Jackson, Jim Jackson, also has a heavy research interest in post-ICU cognition, and so that's how I got him into my clinic. So we really have to cobble together until we have an established care pathway for post-ICU patients like we have for stroke, for example. Then we might have to cobble together something from our local resources, and that could be a combination of hospital resources, clinic resources, research resources, and volunteer effort.
Thank you. Thank you so much.
Thank you for having me. It was really a pleasure.
Thank you, Dr. Seven and Dr. Couture. That was fantastic. Next up, we have another very important topic presented by Ariane Dowdell, Houston Methodist First VP and Chief of Diversity, Equity, and Inclusion. Graduate of Syracuse University, she received her law degree from Wayne State University. In her distinguished career, Ms. Dowdell has held positions at major institutions, including Rockefeller and Virginia Commonwealth University. Diversity encompasses a wide array of differences that include race, gender, religion, sexual orientation, ethnicity, nationality, socioeconomic status, and many more. We all subscribe to the notion of equality and diversity, but we may not know how to make it actionable and implement it at the grassroots level. We are all proud and excited to have Ms. Dowdell on our Houston Methodist team working on this very important issue. Here to talk about DEI in critical care, please welcome our Chief DEI Officer, Ariane Dowdell.
Good afternoon, good evening. I know that I'm the last person, I think, for today, so thanks for staying involved and engaged these last couple of minutes, and I'll make sure I try to keep to my time. So I wanted to talk to you all today about DEI, as I oftentimes call it, in critical care, and also let you guys know what we're doing here at Houston Methodist, just to kind of give you all things to think about as you go through your practice during the day. I'm really on the people side of things, so I was very intrigued by the other presentations that have taken place today. And of course, I always think about DEI from, when people speak to me on a daily basis. All right. Let's see. So oftentimes people say, why should I even consider DEI in critical care? And I just wanted to give you all some things just to start off with. Think about the diverse patient experiences that we all have. And think about the trust that your patients have with you when they come into a room, oftentimes unable to speak. They're putting their trust into you. So think about what that experience is. We bring with us, when we go to work or when our patients come with us, we bring with us those experiences from the past. We can't leave those things at the door. So think about the experiences that those may have before they come to you. Think about the various customs and traditions that people have. And especially here in Houston, we know that there are various customs and traditions that we must consider in everything we do. And again, those things don't fall short when we think about the care that we're giving to our patients each day. We also have to think about the changing populations in the U.S. I know that things have vastly changed just since I've been in Houston in 5 years, and around the country and the world, they're continuing to change. And so we must pay attention to those changes. We have to think about the demographics as well as health disparities, and I probably could honestly talk for an hour on each of these topics, but I just wanted to give you all a general overview of what some of these things mean. But when we talk about DEI here at Houston Methodist, I wanted to just quickly go through what do each of these things mean in healthcare. So when we think about diversity, we're thinking about understanding the background of our employees and patients being served, including their culture, their gender, their sexual orientation, religious beliefs, and even socioeconomic status. When we think about equity, we're thinking about ensuring that our patients have what they need, both in and out of the treatment settings, to effectively benefit from best practices, not to be confused ever with equality. They are vastly different. Think about inclusion, giving patients a voice to help provide and receive high-quality care and encouraging the presence of diverse healthcare staff in the treatment experiences of our patients. And remember that sometimes when our patients are with us, silence speaks volumes. Just remember that silence speaks volumes. I can tell you my father's been in our West Hospital for 3 weeks and cannot speak as he suffers from the final stages of Alzheimer's, and you see him talk with his eyes. He expresses his need for food. He tries to raise his hand when he's happy. So even though someone may not have a voice, make sure that they're included in the decisions that are being made. And also, think about the different generations. So when you think about people from before the 1980s, when they talk about diversity and inclusion, oftentimes they're thinking about that aspect of fairness. Kind of like who gets the trophy at the end of the game. But when you think about folks that are a little bit younger that have come after 1980, they think about diversity, equity, inclusion in a different way. They tend to think about it as a variety of cultures that are coming together and their different perspectives. So there's some aspects of people that think about perspectives, and there's other people that think about fairness. And the two have to be able to mesh together. Looking at some of the demographics, I wanted to show you of Houston versus Houston Methodist. So you'll see at the top the demographics of Houston, and then right below it, Houston Methodist. So when we look on the left-hand side of the screen, you'll see the breakdown of Houston ages 20 through 70. And we fare pretty good here at Houston Methodist with our breakdown. We represent all these age groups with only 1% and 70% 70 years old and older, but we do have great representation. And some people may say the same on the right-hand side, right? When you see Houston up top and then Houston Methodist below, when we think about the representation of Asians, Blacks, Hispanic, or Latino, and whites. But what I'll say to you is that even though you see a fairly good breakdown at the bottom, we have to make sure that that occurs at all levels, right? So when we think about 28,000 employees here at Houston Methodist, you say, my goodness, you guys are doing great. And we are, obviously, but there's always work to be done, right? It's constantly changing. But when we think about representation and the patients that come in, early representation matters. It matters tremendously. So you'll see here, and there's been a lot of conversation that's gone on about who's matriculating through med school right now. And so my kids, I have 3 kids, and they oftentimes are on social media. And I looked at the numbers below when I saw this graph. And if you look at the numbers of American Indian, Black or African American, Hispanic, multiple race, Native Hawaiian, that number below of people that are matriculating through med school from 2018 to 2019 is less than some people's Instagram followers or TikTok followers. It's kind of crazy, but I thought about that. You see people that have 1 million followers or 5,000 followers, but we barely have those numbers coming through our med schools. And so we want to make sure that our physicians represent our patients, and that's not happening right now in med school. So we have to make sure that we, as an organization at Houston Methodist, are involved in early representation and pipeline from middle school and up to encourage students to become physicians, so that when our patients come in here, they feel comfortable. They see people that understand their cultures and traditions. They see people that look like them. That is very important. So I wanted to share that little tidbit with you just to understand the importance of representation. So people have said, Arian, what in the world does your department do? I've been in this role since 2020, and many people think that this is kind of an of-the-moment type thing, but I can tell you Houston Methodist has been at this for a long time. It just hasn't been formalized. But I wanted to tell you a little bit about what we do as a department, so that the places that you all work at, you can think about whether you have a DEI department or not, what can you do to enhance diversity, equity, and inclusion. So some of the things that we have done in the past year, our team, is we train system-wide across all of our hospitals on anti-racism, anti-bias, and what does DEI mean? Because a lot of people, quite honestly, get intimidated when they hear these 3 words. We're also working, and I'll talk about this a little bit later, to close the gap on health and equity. We provide DEI-related resources to support teams. So the issues that may manifest for a nurse are different than those that folks in corporate may have, than those that our transporters may have. And so our role in this department is to make sure that we're helping teams have these conversations and address these issues. We also look at data to look at trends, and I'll show you all a snapshot of our DEI dashboard. And we develop programs and events, as well as make sure that we're always paying attention to our employees, our patients, and our community. So when people say, who is your target audience? I always say every single thing that we do, we think about our employees, our patients, and our community. When we first came into existence, our DEI committee of the board was formed, which is very rare but very important to have done because it shows commitment from our leadership. And so I was really excited to see that we had 5 goals that we had to make sure that we paid attention to for the next 2 years. And I'm proud to say I think we're actually doing pretty good, if I can give some kudos to our team. But these are the 5 areas that we focused on for the past 2 years. Increasing underrepresented group diversity in the workplace, which means early pipeline engagement, making sure that folks that maybe aren't in a clinical setting or have opportunities for advancement in various ways. We need to make sure that we're engaging key stakeholders, both internally and externally. I mentioned that we're working on increasing cultural awareness. We're also developing resources, as well as measuring our community impact, which is very, very important. People don't always think about the importance of our community when we think about the work we do, but that's oftentimes what brings people through the doors of the hospital every day, as well as our employees, making sure that they're happy here because honestly, when they leave, they talk about Houston Methodist and they represent us in the volunteer work that they do. So how does DEI impact patient care? I wanted to show you a couple of pros and cons to think about. So when we have DEI really at the forefront of what it is that we do every day, higher quality of care for diverse patient populations is evident in everything that we do. It increases our patient satisfaction, which we all know is very important. Better problem solving and innovation, which here at Houston Methodist is key to what we do with innovation. We also see a reduction in health disparities and better outcomes for our patients. Patients are following up on their care when they leave. They're happy with where we are because we're acknowledging them as individuals, bringing what they bring to this hospital when they arrive. But when DEI is not present, there's oftentimes communication breakdowns. Patients may leave and not understand what do I do next? I'm just leaving and I have no clue where do I go for my prescription? Who do I call next? What do I do to pay a bill? Those simple things really do make a difference when you're thinking about patients from diverse populations. We also have limited perspectives and ideas. I often tell people that if we're hiring and looking for the best physicians or the best chiefs of a new position, if you have everyone that looks like you in the room, you're probably going to hire someone that looks like you. So it's not effective to just have a diverse slate of candidates, right? Because there's no expansive ideas and perspectives. So we have to diversify who's at the table when it comes to hiring. And we all have biases. I know we don't like to admit it, but we do. And so until we feel comfortable having those conversations about what those are, we really can't address them. So one of the things that we've done for all of our employees is make sure, in addition to the training that we have, that they also have a DEI toolkit. We know that people like to learn in different ways. Leaders have said, can I have something where then after they go through training that I can work with them to continue these conversations where maybe I can't answer the questions, but I can become a little bit more knowledgeable on what I'm doing. So we have this available on our internal website, our SharePoint, where people can go and depending on what it is they want to do, they can click on any one of these activities and they can do these. They can spend time reading just to enhance their own learning. And so this is something that's evergreen. Our employees even provide us with suggestions. But the goal is to make sure that we're constantly educating everyone in the ways that they choose to be educated. We also are working to have DEI roundtable discussions. So these will be small group discussions where we talk about various things, including how do we improve our patient experience when it comes to diverse populations? How do we increase our patient care? How do we make sure that our staff is culturally competent? That is a big one that we've been asked to do. So we'll be starting these in the fall, having these conversations. And then these are just some other things to consider, and I'll be mindful of time, but knowing when it's time to use interpreter services. How do you address confidentiality concerns with people that maybe don't understand what that means in totality? Think about their cultures again. Think about your communication style and how it meshes with those that you work with, as well as your patients and their families. So these are just some quick things to consider. We also want to make sure that folks are overcoming their barriers, and so these are some examples, but I'll skip through due to time. How do I go back? Let's see. So I wanted to give you all a quick scenario that we've definitely brought to some folks to make them think a little bit. So a 66-year-old Hispanic male, as identified on his paperwork, arrives for an outpatient procedure, and he's accompanied by his daughter who will drive him home afterwards. And so the doctor enters the room and immediately addresses the daughter instead of the patient. The doctor then proceeds to speak to him very slowly, assuming that the patient does not speak fluent English because he checked off that he was Hispanic upon his arrival. So that physician is automatically making assumptions about a patient that may or may not be true. And so the result of that is oftentimes the patient is feeling ignored, thinks the doctor is rude, even though the doctor feels like he's probably doing the best thing that he can, or she, because I don't know if Dr. Y is a he or a she, or other. The patient might have their trust broken, and the expectations of care are lowered. Remember, I mentioned that silence also speaks volumes, and that oftentimes happens. And also, the intelligence of the patient is oftentimes undermined in these situations. Another example is I have a daughter that has special needs, and so she has something called Jacobson syndrome. So if you give her 5 or 6 steps at one time, it's hard for her to process. If you go through 2, she's okay. But if you go through 6 at once, she's no good. So she's at the doctor's office, and they said, Addison, I need you to go to the back. I need you to change into your robe. I need you to put your bags in the locker, right? I need you to sit and wait and open the door. It's about 20 minutes go by. I'm in the waiting area. I don't see this little girl walking by, and I'm thinking, where is Addison? But I'm going to leave her alone, let her figure it out. And so the tech comes out and says, well, where in the world is Addison? I said, I don't know. I said, you gave her those steps. Did you follow up? Well, poor Addison got to the point where she put her robe on, right, for her x-ray. She put her stuff in the cabinet, but she was so confused that all she could do was sit there because nobody took the time to think maybe these steps are too much, right? So that time went by where that particular patient, when she walked in, nobody would have known that she had a disability. You don't see it. But that disability was felt by my daughter in that moment when she waited, wondering, why is it taking so long? So the smallest things, right, can become so big for a patient even though it's all unintended, right? So we have to think about, even when we think we're doing our best, are we doing enough? And that's what I want to encourage you all today is, are we doing enough? In such a fast-paced environment, everybody comes with different parts of themselves that you just have to figure out, how do we maneuver that? But that's just an example I wanted to share with you all. So in addition to the other things that we've been working on, as I mentioned, the community is very important. And so we have a $25 million grant that was established last year, and we're giving out that grant at $5 million each year. And so we have 2 different vehicle grants, our DEI grant as well as our social equity grant. And so I was very excited that for our first year, we gave out $2.476 million to help approximately 55,000 people. And this year we're expected to double that number of funding that will go out to various community partners. And what we're looking to do is not just give money to these organizations, but to truly create partnerships. Our community benefits department is quite incredible. They've been around since the 90s and do amazing work. And this is just additional work that we're doing from the DEI side, where we can work with these agencies to really look at some of the root cause issues that get to these things we talk about, whether it be homeless housing, or helping abuse victims, or sickle cell patients get adequate care. These are just some of the groups that we've worked with this first year. And again, this number has doubled, but you'll see the organizations that we have on here are very different. So for example, the South Texas College of Law, and I'm probably biased that I looked at that because I used to be a lawyer, so I promise my eyes just went there. But they work with folks to help them expunge their records. You don't see too many organizations that teach their law school students to do that, to make sure that they have a chance to then get better employment, to have future careers. Some of us never have had to think about expungement, right? But that is a huge deal. And so having an organization that wants to work to create those opportunities for folks to start again is very important. And we've also talked about briefly our health inequities and what is it that we want to do when it comes to this area at Houston Methodist. And it's been a key focus for us the past 6 months. So these are some of the things that happen when health inequities exist. Oftentimes we see people with lower income, not the best insurance, fewer transportation options, less social support, less knowledge, and more comorbidities. And so these are all factors that play into the inequities that exist that we here at Houston Methodist are making sure that we're addressing. And in doing so, we've put together a group of 14 different clinicians that have come together to set some priorities for us to really begin to have conversations about how do we address the health equity gap. And so you'll see on your right-hand side our 3 sub-priorities for this first year. So we're looking at our continuum of care, we're looking at multi-visit patient identification and intervention, and we're also paying attention to social determinants of health. And what we're looking to do is to create a repository. Well, we'll have the different work that our clinicians are doing throughout the hospital to address these issues so that then we can begin to educate others to lessen the divide over time. So I'm really excited that now that hopefully we're starting to come out of COVID, we'll be able to make a real impact when it comes to health equity here at Houston Methodist. And I think this may be my last slide, but I mentioned that we have a DEI dashboard. And so when I started in 2020, I thought it was really important for us to have data. Data tells a huge story. And so we asked if we could put this together, and you'll see at the top that there's data available on our clinical side as well as our employee side. Those are the primary areas of this dashboard. We also have information on spiritual care, which I'll talk about, as well as our Community Scholars Program and our network of care. But you'll see that we had data from 2019, this is just a snapshot, up to 2021, and with this, we're able to look at all of our Houston Methodist hospitals, and it allows us on the left-hand side to toggle and look at different areas, whether it's your financial class group, race and ethnicity, and gender, to see how we're doing as an organization. And so what we've started to do internally, more on the employee side to start, is we've been starting to work with departments to have them really look at a snapshot of their department. You'd be surprised at how people really don't know what the makeup is of this organization or their departments for the really large departments. And so we talk to them, and we're working to create DEI scorecards where people can say, this is my measurable goal. So for example, I have a department that looked, and they have tenure that is absolutely fantastic. People have been here for 10, 15 years. It's really wonderful. They don't have all the high turnover. The problem is there's a lot of folks that will be aging out and retiring soon. And so what's going to happen to that wealth of knowledge? And you have nobody else that you're bringing in, right, to do succession planning. So we have these conversations. We set targets and goals with them. And we'll be doing the same with clinicians as well. We've talked to some about what their goals look like when it comes to diversity, equity, and inclusion. I can say that even though this is a very robust tool, which is great, we don't make it available to everyone within the organization for a reason, which is because you can take a snapshot in time and make it the full story. And unless you really know how to utilize this tool, it's only going to be as good as how much you know. So we take the time to walk folks through this, and we have certain people that do have access. But this is something that will grow over time and that we'll provide in our annual report. We had our first annual report that came out this past year. We'll provide statistics so that people understand what we're doing really well and what we want to focus on moving forward, because we realize there still is quite a bit of work that we would like to do here at Houston Methodist. And so as I close out, I just wanted to give you all some things to think about when it comes to diversity, equity, inclusion, and critical care. Again, I could go on and on, with specifics directly towards you all, but I just want you to take some time to think about what does the care for each of your individual patients look like, and where can you do better, and where can you celebrate those areas, that you're already excelling in. So thank you so much for having me. I appreciate it. I don't think it was on.
Thank you, Arian. Fantastic speaking. I just want to get 2 comments for the audience. First of all, we actually, in the Center for Critical Care, are starting a DEI initiative with Erin Dowdell and her team. We're going to be looking at 2 main aspects. We want to have a better understanding of what kind of patients come to intensive care, what are the challenges, whether it's income related, zip code related, adverse events wise. Also, we want to look at what happens to their care during their stay in Methodist Hospital and even after they get discharged. So that hasn't really happened in the state of Texas that we know of, and we're very glad to have partnered that we're going to start that work this year. That's one thing I want to share. The second I want to share that there's a Lowen Institute which looked at 275 healthcare system nonprofit across the country, and they wanted to understand as to the tax benefits and what they give back to the community. Out of the 275 non-profit healthcare system, 225 got more tax benefit compared to what they gave back to the community. So guess where Houston Methodist lies? We are number 5 in the nation, healthcare system into giving back more to the community compared to our tax benefit. So we're number 5 in the nation. Just want to share with that.
This has been a remarkable day. We're not done yet. We will reconvene tomorrow. Don't get nervous. Today we are done. At 7 a.m. sharp for our second exciting day. We'll have 7 more great presentations, and then we'll have our breakout sessions and our in-person workshops. So enjoy your Friday night, and see you bright and early.